I don't know why. So please accept my apologize and my excuse. So can I continue? Okay, I think it was a problem with the Zoom application because all of you are kicked out. I think it was a problem for all of us. We're gonna wait just a few minutes. We will wait the other participant to sign in. Okay, so if we can just, if you allow me just to wait a few minutes, just to let all the participants be present. Okay, so I will continue with the, so I don't know if we're gonna go back to the post-surgery cardiac rehabilitation. Okay, so how to perform physiotherapy before operation. Okay, I think it's better to go back for one slide. Okay, so let's talk about the physiotherapy with post cardiac surgery. So as I said, physiotherapy after cardiac surgery helps patient lead an everyday life and helps in improving their situation and saving them from sudden death. So they can also reduce mortality, improve health and quality of life, reduce the length of hospital days, also reduce the number of hospital readmission, and help to return to work and self-management of the condition. So here we can talk also about the three central physiotherapy involvement in this at this level. So rehabilitation, chest care, and mobilization. So after surgery, physical therapy is constantly prescribed to bring back mobility in the affected area. The second most important reason is pain management. Physiotherapy lessens the pain of person feels after surgery. So we give exercises to strengthen the body and exercises to enhance mobility of the body. Moving to the how to perform physiotherapy. So first of all, we have the physiotherapy before operation. So before surgical procedure, physiotherapist will provide with some essential learning on what's required to help patient recover as smoothly as and quickly as possible. So here we have the breathing physical activity and the support coughing. As per the breathing physical activities, so breathing sports are critical to saving the chest complication after surgical procedure. including chest contamination and lung collapse. Also practice deep respiration sports earlier than the operation, and it will likely be simpler to do this afterward or after the surgery. And also have the support cuffing. After the operation, it's essential to cuff to clear any sputum. So the chest wound is supported by holding a pillow or rolled up towel firmly against the chest. So we ask the patient to support and or to hold a pillow or rolled up towel, and so to hold it firmly against the chest and leaning slightly forward. The physiotherapy after the surgery. At this level, we have the exercises. So after the operation, these exercises help remove the secretion produced from the lung leaning general anesthetic, and which can lead to pneumonia if left of the lungs. So exercises after the operation, we have the deep breathing exercises, which take 5 deep, it's like taking 5 deep breaths every hour, and then blow up and cough to clear any lungs. Use a spirometer and take 5 breaths every hour. The exercises number 2 is the leg exercise. At this level, the exercise increase here circulation and prevent clots from forming in the leg and chest. So we should do the ankle exercises, quadriceps exercises, gluteal exercises, and gluteal exercises and straight leg raising 10 times every hour. So at this level, talking quickly about the ankle exercises. So ask patient to move feet up and down at the ankles and repeat it 10 times every hour. As per the quadriceps, ask him to press the back of the knee again toward the bed. So press on the bed. Heels have to elevate away from the bed at the same time. We have also the gluteal exercise. Ask patient to tighten buttocks together for 5 seconds and relax. As per the straight leg raising, ask him to lift the leg of the bed and preserving the knee straight. The stretching physical activity to save the patient from stiffness is very important. So here we have 6 examples: extension in sitting, rotation in sitting, rotation in so rotation in sitting and side bend in sitting, shoulder extension and shoulder flexion. Okay, starting with the extension in sitting, it's to ask patient to sitting tall with back and neck straight and shoulder again slightly, gently take neck backward until experience a stretch pain-free, and repeating the cycling slightly 5 times. Rotation in sittings, patient should keep neck directly and don't permit head to poke forward at some movement. And also we have the rotation sitting. Begin sitting tall with arm across the chest and keeping legs still, gently rotate to at least one side until feel mild to moderate pain-free stretches. And we have, as we said, the shoulder extension and the shoulder flexion, and repeat this exercises 5 times. Here's some quick exercises. I'm not gonna go into details, but we're gonna see some shoulder exercises. These exercises can are to help ease off some of the stiffness or aching. So it may develop following heart operation. So the aching due to the heart operation. So they should be done slowly. Aim to do them twice a day, starting with 5 of each and gradually building up until doing 10 of each. Some trunk exercises, it's easy. You can, as you can see, it's alternate side bending. So bend sideways to the left without leaning. Also, we should slide fingers towards knee and count to 5 and slowly return to standing to the initial position and repeat to the right side. And the other one is the upper body rotation, sitting with hands across the chest, slowly turn to the right and hold for count 5 and repeat to the left. Return to activity after surgery. As per the driving, usually the patient can drive around or after 6 to 8 weeks after the operation or after the surgery. He can swim 2 to 3 months after the surgery. All wounds need to be completely healed before swimming. Dancing after 2 months, jogging after 3 months or after cardiac rehabilitation class, cycling outdoor after 3 months or 3 months after the surgery, static exercise bike at home should be discussed with the physiotherapist or the doctor as a specialist. And the work depends on occupation, depend on the job. Patient needs to seek the consultant advice. He can do light work after 2 months from the surgery. He can do manual work 4 months after the surgery. More active sporting activities. Here, the patient should follow doctor's advice or physiotherapist at post-surgical discussion or exercise group. Return to activity after minimally invasive surgery. For 4 to 6 weeks, care should be taken with an activity or posture which involves overstretching right groin where surgeon accessed your artery. So driving consultant advice at clinic, non-strenuous activity after 2 to 4 weeks, and heavy lifting after 6 to 8 weeks, cardiac rehabilitation exercises class. So if we have a minimal invasive surgery, the driving, so we should, patient should consult advice at clinic or ask the surgeon and do some non-strenuous activity. And per the heavy lifting will be after 6 to 8 weeks from the surgery. General advice, following cardiac surgery, it's natural to experience new aches and pains and stiffness in chest, back and neck areas, stiffness. This does not resemble angina pain. It may take 2 to 3 months before it completely resolves. Patients should do no lift and carry or push or pull anything heavy for at least 6 weeks until breast bone heals. Avoid sudden exertion or exercise which will put an unexpected load on heart. Building up gradually is therefore important. So never continue to exercise if the patient feels or experience palpitation, undue shortness of breath, extreme fatigue, or dizziness. Patient should also not exercise on a full stomach. Better not to walk with a dog on a lead for the first week. Okay. So physiotherapy play a crucial role in the improvement of a patient's condition. Physiotherapy helps patients return to their everyday lives. Thank you so much. If you have any question, I'm ready to answer. And I'm sorry again for this technical issue or technical problem. Okay, if there is no question, we're gonna take just 5 minutes break and then we move to the second session, which is moving and handling of patient post-procedure. Okay, thank you so much. So we will be back in 5 minutes. presentation, I'll be speaking about the moving and handling of patient post-procedure. What we will talk about? We will talk about injury risk, about myth and verse facts, musculoskeletal disorder, body mechanics and ergonomics, using a patient lift and proper lifting technique. So as you know, the moving and handling, so it's a big part of patient care and the safe lifting and handling of patients. So many caregivers are injured each year. ممكن كلنا مرقنا بهالتجربة. So many caregivers are injured each year due to patient handling. So it's important to understand then that when dealing with patients and what you need to consider proper body mechanics, ergonomics, and the patient's safety. Starting with the injury risk, we have the rates of musculoskeletal injuries from overexertion in healthcare occupations are among the highest industry. So أكثر شيء ممكن injuries صايرة musculoskeletal at the healthcare providers. So Bureau of Labor Statistics, on average, rate of overexertion injury across all industries is 38 per 10,000 full-time workers, which is high. The rate for hospital workers, twice the average, so 76 per 10,000. Nursing home workers, 3 times the average, so it's 132 per 10,000. The ambulance workers is 6 times the average, is 238 per 10,000. Single greatest risk factor is manual patient handling. So this is the biggest risk factor, it's the manual patient handling. What about the more risk? Rising obesity rates in general have increased physical demands on caregivers. Aging workforce, average age of registered nurses is 47. Ongoing shortage of nurses, other caregivers, and healthcare organization cutting workforce and longer work schedule. So unfortunately, as I told you, the rate of obese people is rising, and this fact puts more physical demands on caregiver. And the average age is 47 years old, so it's high. And in addition, many caregivers are now working longer schedule and are required to rotate between different care areas. Some statistics, 52% of nurses experience chronic pain or chronic back pain. 12% leave nursing because of back pain, and 20% transfer to a different unit due to back pain. So back pain is the leading cause of disability to nurses under 45 years age. Study and findings, musculoskeletal injuries. There is a study for Pompey and all, talking about musculoskeletal injuries resulting from patient handling tasks among hospital workers. And it was published in the American Journal of Industrial Medicine. These studies show us the distribution and the crude rates and adjusted rates ratio of patient handling injuries. Inpatient nurse, so we have the population of 861. The inpatient nurse is 431, almost or 50% from the total. Nurses aid is 199, so 23.1%. Radiology technician, 95, it's around 11%. Outpatient nurse, 3.8%. Physical and occupational therapist, 2.9%. and the others is 1.6 and 1.4. Okay, it's patient transporter, morgue, descent, car technician, secretary, operation room, etc. But which is very important here, and we should take it into consideration. It's the inpatient nurse and nurses aid, which is 50% and 23%, and the radiologist, the radiology technician. Injury claim resulting from patient handling nurses and nurses aides. So if you can see here, injuries claims which came from the nurses and the nurses aid, especially from lifting patients, which is 22%, caused by this injury are caused by lifting patients. So 22% is the higher percentage. Then we have the assist, which is 20%, and then 17% for pull up in bed, 13% for both transfer patients and reposition patients, 10% for transport in bed and chair, and 5% code patient. So moving patient myth versus facts. So there are some myths about moving patients, such as worker can be trained to use proper body mechanics, whereas more than 3 years of research and experience shows that relying on proper body mechanics or manual lifting is not effective to reduce injury. The fact is more than 30 years of research and experience shows relying on proper body mechanics or manual lifting alone is not effective to reduce back or other musculoskeletal problems. So the second myth is patients are not as comfortable as safe with mechanical lifting. The fact is patient education can reinforce that the lift is for the patient's safety as well as the caregivers. Patient handling equipment can prevent falls, bruises, and skin tears. So moving patients myth versus fact. It takes less time to manually move patients than to use lifting equipment. So if we're gonna, it will be quick, as if you want, to move the patient manually, which is not true. The fact it can actually take much longer to get a team of co-workers together to manually lift a patient. So together, to gather all the stuff will take time. So attempting to lift a patient by only one person puts that caregiver at risk of injuries. Using mechanical devices take fewer personnel and about not more than 5 minutes using the left or the devices. What about the musculoskeletal disorder? At the level of the nurses, they can feel injury or disorder of the muscles, nerves, tendons, joints, cartilage, spinal discs, and also at the stages of, there is a stages of musculoskeletal disorder. There is an early stage, intermediate stage, and advanced stage. At the early stage, pain may disappear after a rest away from work. At the intermediate stage, body part acts and feels weak soon after starting work and lasts until well after finishing work. As per the advanced stage, body part acts and feel weak even at rest. So the patient feel weak even at rest. Sleep may be affected, and light tasks are difficult on days off. Some symptoms which we should not ignore this is so we have the pain, the burning, the swelling, cramping, stiffness, loss of color, tingling, numbness, and weakness. Some common musculoskeletal disorder, you have the strains and sprains, so neck, back, and shoulders, the lower back pain and sciatica, bulging or herniated spinal disc, carpal tunnel syndrome, tendinitis and tenosynovitis upper extremities, epicondylitis, tennis elbow and golfer's elbow, rotator cuff tear at the shoulder, and bursitis, shoulder or knees. What about the primary risk factors for musculoskeletal disorders? So the risk factor are conditions of a job that contribute to the risk of developing a MSD. So exposure does not guarantee injury, but increase the likelihood. We have the three primary risk factors, which are the force, the repetition, and the awkward and static posture. As per the force, example of force includes heavy lifting, pushing, pulling, or excessively squeezing a hand tool, such as a hammer. The awkward posture, example of awkward posture include reaching overhead, bending to ground level to lift a box, or looking down at a laptop monitor. As per the repetition and duration, examples include repeating similar motion action over the course of a workday. If the duration of these actions are repeated is increased, the more likely an injury such as musculoskeletal disorder will occur. So the awkward posture and at the MSD, this is the position of the body when performing physical tasks. So the awkward posture caused by mechanical stress to joint and surrounding soft tissues, strength of the body part is decreased, accelerating muscles fatigue and increasing risk of injuries. So there is some here's some example: bending, twisting, reaching overhead, kneeling, squatting, and pinch grips. Also, an example is providing medical care or performing personal hygiene tasks when the patient is in a chair or bed that is too low. So, we should bend to do the to perform the care or to do the care. Accessing medical equipment such as in-wall oxygen or suction equipment. Also, there is a manually reposition of or transferring the patient. Static or fixed posture definition: the posture are work position that are held for a period of time. So blood supply reduced to muscle, which lead to a muscle fatigue. Static or fixed posture and MSD, example, prolonged standing or sitting, performing patient care tasks, or making a bed while bending forward at the waist for a few minutes or longer, which can hurt your back. So supporting also a patient extremities or heavy instruments during a nursing task or a medical procedure. As per the force and musculoskeletal disorders, amount of physical exertion or muscle effort expended when performing a task or activity, such as lifting, pushing, pulling, carrying, or gripping tool or equipment. The greater the force exerted and or sustained over time accelerate muscle fatigue and increases risk of injuries. The amount of force exerted is influenced by the weight and shape and condition of the patient or equipment. Also, it influenced by the body posture used, number of repetition performed, and duration or length of time the task is performed. Example, load or patient shift suddenly or unexpectedly, lifting a bariatric or obese patient, or for example, pushing a stretcher with poorly maintained or incorrect casters. As per the petition, it's performing the same motion over and over again. Example, repeated positioning of patient in bed or transfers to chair, which can be done more than a few times per day. The cumulative effects, duration of exposure to risk factors, it's really very important. The duration of exposure to risk. So it's affected by working through breaks, overtime, task variability. So when we ask us to work during our break or to do overtime or to do a task out of our job description or variability of tasks. So all of this, it can hurt us when the musculoskeletal system is exposed to a combination of this risk factor too quickly, too often, and for too long. So too quickly, too often, and too long, without sufficient recovery or rest time. So here, damage occurs. Here, the cumulative effect. So continued exposure to risk factors, as I said before, over a long time, lead from fatigue to discomfort to pain, which can lead also to injuries and disability. Patient handling higher tasks, higher risk tasks. So transfer from bed to chair or stretcher, manually moving patient in bed or manually lifting from floor or attempting to stop falls. This is a high risk of damage. Before patient handling, just here we're gonna talk a little bit about some hint or some tips. So before patient handling, wear the right clothes. So make sure your clothing and the footwear are appropriate. Clothes should allow free movement and shoes should be non-slip, supportive and stable. Also, know your limits. It means know your own capabilities and don't exceed them, for instance. So if you need training in the technique to be used, tell your supervisor. Also, do one thing at a time. Don't try to do two things at once. For instance, don't try to adjust the patient's clothing during the transfer, for example. Also, prepare for the task. Prepare yourself for the task. So make sure everything is ready before you start. For instance, so check other caregivers are available. If needed, equipment is ready and the handling environment is prepared. Apply safe principles. Always use safe body mechanics and use rhythm and timing to add the task. Here's some elements of a best practice patient handling program. So ergonomic assessment protocol, which is assess the hospital environment, examine injury rates, and also identify high-risk units. Patient assessment criteria, which is the tools to help nurses evaluate patient characteristics that affect decision-making and decision-making about equipment and techniques for safe patient handling. There is also the algorithm for patient handling movement. There is a standardized process for making decision about the equipment and the number of staff necessary to perform high-risk activity safely. We will see it in a later on. Secretion of patient handling equipment, mechanical or non-mechanical. So ensuring that the right equipment is available in sufficient quantities and kept in a convenient location and in operating condition. Burns back injury resource nurses. So Burns back injury resource nurses is a peers selected for high-risk nurses units who are especially trained in the identification of workplace hazard. So the role also includes on-site training and evaluation of peers regarding the proper use of equipment. We have also the after-action review, knowledge the team has gained by performing a task in one setting and how it is applied in a different setting. To finish with this, we have the no lift policy or minimal manual lift policy. Establishes an agreement among staff members that they will use the safest approach to handling and moving patients. Indicates support from management that safe patient handling practice which should be used. So patient assessment criteria, it's as I said, it's a tool to help nurses evaluate patient characteristics that affect decision-making about equipment and techniques for safe patient handling. So this is the assessment tools for safe patient handling and movement. We have 6 questions. The first one is, what is the level of assistance required by the patient? So, for example, the patient is independent and performs the task safely. The patient can provide partial assistance, or the patient is dependent and requires more than 50% of assistance. The second question is, what is the patient's weight bearing capability? The patient can bear his full weight, his partial weight, or his own weight. The question number 3, does the patient have the upper extremity strength needed to support this weight during transfers? Yes or no? The first question is about patient's level of cooperation and comprehension. And the patient cooperative, is the patient cooperative and able to comprehend instruction? If yes, the patient is cooperative, and if no, the patient is either unpredictable, not always cooperative. The question number 5, patient size, the weight and height. Question number 6, check applicable conditions likely to affect patient handling and movement tasks. So if there is an abdominal surgery, wounds, or hip or knee replacement, postural hypotension, bilateral amputation, fracture, pressure ulcers, contracture or spasm, etc. And there is a space here for the comments or other, if you want, other notes. So there is also an algorithm for patient handling movement. It's a standardized process for making a decision about the equipment and the number of staff necessary to perform high-risk activity safely. So we have this algorithm. It's like a form to be filled. There is 5 questions or 5 points. The first one is transfer to and from. We should specify if the transfer is from bed and chair, or chair and toilet, chair and chair, or car and chair. What are the equipments or the assistive device we need, and the number of staff needed. The second one is lateral transfer to and from bed and stretcher or bathing trolley, etc. Also, we should specify the equipments and the number of staff. Transfer to and from chair and stretcher. The first one is repositioning in bed from side to side and repositioning in chair. All of this question require the equipment and the assistive device and the number of staff. And also there is a space for comments and sling type, standard amputation, head support, etc. If it's standard, so it's a normal patient. If there is an amputation or there is we need a head support as for the tetraplegic, for example. And sling size, the signature and date. It's like a kind of form to request the help for transfer. Lateral transfer to and from bed and stretcher or bathing trolley, this is an algorithm. We start here, and then the patient we ask when the patient can assist. If partially or not at all, we ask if he is less than 200 pounds, so use a friction reducing device. If the patient cannot assist or partially, if he is more than 200 pounds, we should use a friction reducing device and 3 caregivers. If the patient can assist, we move directly to caregiver assistant not needed, so he can stand by for safety as needed. So here surfaces should be even for all lateral patient moves. With patient with stage 3 or 4 pressure ulcers or so the stage 3 or 4 of ulcers, so patient must be taken to avoid shearing force. There is also a patient handling versus other lifting. So the load is often unstable, the load of the patient. The patient do not have handles, so we don't have handles to pull the patient. A patient's weight is distributed unevenly, and a patient may be combative. Patient handling methods must come in soft or body mechanics and the principle of ergonomics. Important principles, body mechanics, we have the stand. So here, as we said, the most common methods for safely handling patient are using proper body mechanics and ergonomics. And in many healthcare organizations, training is provided to all employees that relates to both of this subject. So importance principle, body mechanics, we have the stand in a stable position or avoid twisting, bend your knee, elbows in, tighten abdominal muscles, head up, move smoothly. So here we should apply safe body mechanics and maintain the natural curve of your spine to minimize the force on joints and discs. So they stand in a stable position, so the feet should be shoulder width apart and with one leg slightly forward to help finding the balance. And also we may need to move feet to maintain a stable posture. Avoid twisting. Make sure your shoulder and pelvis stay in the line with each other. Bend your knees. So bend your knees slightly, but maintain your natural spinal curve. Avoid stopping by bending slightly at the hips. The elbows should be tucked in and avoid reaching further away from the body. The load is the greater potential for harm. So head up, for example, keep your head raised with your chin tucked in during the movement. And move smoothly throughout the technique and avoid fixed hold. So when handling and moving patient, maintain a weight stable base on your feet and put the bed at the correct height, so waist level when providing care, hip level when moving a patient. Try to keep the work directly in front of you to avoid rotating the spine. Keep the patient as close to your body as possible to minimize reaching. Caution, body mechanics alone is not sufficient. Ergonomics, we have the ergonomic design, and good ergonomic design. So when working with patient materials or even entering reports on a computer, it's important to have an understanding of ergonomics. So the ergonomics is the science of fitting jobs to people, encompasses the body of knowledge about physical abilities and limitation, as well as other human characteristics relevant to job design. As per the ergonomic design, the application of this body of knowledge to the design of the workplace, tasks, for example, equipment, environment. So it's the design of the workplace for safe and efficient work use. As per the good ergonomic design, make the must use or the most efficient use of worker capabilities while ensuring jobs demands do not exceed those capabilities. Ergonomics risk factors in patient care occupation. Forceful and heavy exertions, it's a risk factor. High frequency repetitive tasks and awkward postures, work duration, it's a risk factor. Uneven work floors, unpredictable patients, dependence level of patients. Ergonomic also risk factors in patient care occupation. Lifting heavy loads is also a risk factor, excessive pushing and pulling, and reaching something. Use caution. There are lifting tasks that are so stressful for the body. Even if proper body mechanics and ergonomics are used, a person can still suffer an injury. So even if the body is good, have a good force, a good strength, and a good shape, sometimes some tasks or lifting tasks could be so stressful to the body. So more than one person team lifting, so more than one person required to lift a load, team of folks, one person calls direction and lifting steps, so everyone will move at the same space. Can be used when the patient is very large or overly obese. Also, team members must still use caution to ensure proper body mechanics and ergonomics issues are addressed. Prepare for safe patients handling. Know what equipment is available and how it works. So we should know our equipment and if it's available and how it works. Assess the patient and the environment, and gather appropriate equipment and stuff needed. Coach patient. Tell the patient what you are going to do and tell him how to interact with you. When and why to use the lifting device. So patient benefits and patient comfort. So we should use the lifting device and the benefit of patients and the patient comfort, and also to respect a patient's sense of dignity and promotes patient independence and rehabilitation. Decreases occupational injuries and indirect costs, including employee replacement, additional training, loss of productivity, and liability. When to use lift, as we said. So for most patient, lifting tasks maximum weight limit is 35 pounds. So patient characteristics that add risk: height, weight, body shape, and dependence. So using patient lifting devices, here it's a good idea to use a patient lift in situation where the task requires any lifting over 35 pounds. In addition, there are certain characteristics of a patient that also affect a decision to use a patient lifting device, such as the height, the weight of the patient, body shape, and patient dependency. When to use a lift? This is a chart of this slide, can be used as a aid for determining when to use a patient lift device. So some of the issues to be taken into consideration if the patient can be any weight themselves and if the patient is cooperative. So starting here, if the patient can bear weight fully, so caregivers assisted not need. If partially, we ask if the patient is cooperative. If yes, we move to stand and pivot technique using a gait belt. If the patient is not cooperative, so we should use fully body sling, lift, and 2 caregivers. If the patient cannot bear weight, we move to we ask if the patient are cooperative. If no, we use the full body sling, lift, and 2 caregivers. If the patient is cooperative, we ask if does the patient have upper extremity strength. If no, we go directly to use the full body sling lift and with the help of 2 caregivers. And if the patient can use the upper extremity strength, if yes, we seated transfer aid may use gait belt until the patient is proficient in completing transfer independent. Employee responsibility. Healthcare employees have the responsibility for the following when it comes to handling patients. So know the characteristic of an unsafe lift, know the help that is available, both coworker and equipment, know your employer's lift policies, and if unsure about the safety of a lift, ask your instructor or director. So here in this photo, what do you see? So there is a nurse who is helping, or a physical therapist, or a healthcare providers who are helping the patient to stand up or to walk. So patient may have difficulty supporting full weight. If patient begins to fall, what will the nurse do? We're going to ask also, can nurse support full weight of patient by herself? Also, it's good to ask if the patient wearing non-slip footwear and floor slipper. So what condition make patient more likely to fall? Usually, it's the lower body weakness, the vitamin D deficiency, the difficulties with walking and balance. Also, if you are taking medicines such as tranquilizers or sedatives or antidepressants. Also, if there is a vision problems or foot pain or poor footwear or home hazard or dangers. So how to sit a patient up in bed? If the person is not strong enough to push up with his or her hand to a sitting position, place one of your arms under the person's legs and your other arms under his or her back. Move person's legs over the edge of the bed while pivoting his or her body, so the person ends up sitting on the edge of the bed. Keep your feet shoulder apart, your knees bent, and your back is a natural straight position. To assist with standing up, position the person's feet on the floor and slightly apart. Then the patient's hands should be on the bed or on your shoulders. Place your arms around the person's back and clasp your hands together. If the patient is wearing a lifting belt, make sure it's fastened around their waist. Grasp the belt when lifting the patient and hold the person close to you. Lean back and shift your weight. To assist with sitting down into a chair or wheelchair or on a bed, pivot toward the chair, bend your knee and lower the person into the chair. So the person should have both hands on the arms of the chair before lowering him or down. Types of transfers. There are several different types of patient transfer that occurs to include from to or from a bed, to or from a chair, to or from a commode toilet, lateral transfers, to or from the floor, or to or from the vehicle. Consideration and planning should be given to each of these transfers to determine the safest methods to accomplish them. As per the repositioning, we have the patient here may need to be repositioned to a chair, bed, and or diagnostic table, for example. Always remember the principles of what you are trying to accomplish and the fact that safety needs to be paramount no matter what you do. Transfers and repositioning factors. So we have the patient factors, personnel, the equipment, and the environment. So when transferring and repositioning a patient, you need to keep several factors in mind. So the patient themselves, for example, how heavy are they and how much mobility do they have? As per the personnel, the people involved with the transfer repositioning, what is their size, strength, physical capability, etc. And per the equipment, so the equipment involved the wheelchair, the bed, the patient lifting device, and as per the environment of the room, we should make sure what type of flooring is in the room and is it well or it's well or not. Patient when involved with patient handling, you need to take into account several items such as the medical condition of the patient, including his or her history. You also need to ascertain what the patient's mental status is. For example, are they cooperative? Do they follow direction, etc. Also, it's a good idea to find out what the patient functional status is. Things like their strength, balance, coordination, and stamina. Base what actions to take when handling the patient on all the factors just covered to ensure the safety of the patient and caregiver alike. As we said before about the environment, remember to think about the environment where the patient handling will take place. Take into account the design of the room, what type of and how much furniture there is in near of the area, and what type of medical equipment, such as, for example, ventilator or others, may be involved. Also, think about the available lighting in the room. Is it sufficient to properly see what needs to be done and where the caregiver and patient will be walking? When planning the actual patient handling activity, the climate and or temperature of the area should be taken into account. Is the room hot or cold, which may necessitate the patient needing a blanket or removing a blanket from the patient. Here, as you can see, it's a wrong position from this caregiver. So this posture could lead to an injury for sure. So what about the personnel? The personal, so the education, training, competency, compliancy, teamwork, and communication. So when handling patient, it's always a good idea to think about those involved in the activity. We should ask, for example, what type of training do they have? Are they competent and capable to safely, properly, and efficiently handle the patient? Also, we can ask if will there be more than one caregiver involved? If yes, can all involved work effectively as a team? They used to work as a team, and what type of communication is necessary between everyone involved? And also we can ask, does everyone speak and understand the same language? Before the task, what should we remember? Check patient profile, seek advice. For example, talk to your manager or the patient handling advisor if you need advice on the techniques and equipment you should be using. Check equipment, ensure equipment is available in good condition with all components in place and ready to use. Prepare handling environment, position furniture correctly, check route and access ways if they are clear or not, and check the destination if it's available. Explain the task. Explain the task to the patient and other caregiver who will be helping. Prepare the patient and ensure the patient's clothes and footwear are appropriate for the task and they have any aids they need, and adjust their clothes, aids and position. Encourage, for example, encourage the patient to lean forward. Give precise instruction, give clear instruction. This helps the caregiver and the patient to work together. Order of operation. So the order of assistance for a patient depends on their level of activity and what type of device is necessary. In order of how much assistance is necessary, the caregiver must ascertain if the patient is independent or not. If the patient is independent, then patient handling should be minimal. If a non-friction or air assistive device, if there is transfer gate belt or lift necessary, then proper preparations should be made before attempting to handle a patient. Safety tips, it's if standing for an extended period of time to make things as a bit easier, as well as utilizing body mechanic. Remember, stand with feet shoulder width apart, place one foot slightly behind the other, shift weight from foot to foot, and repositioning your body if possible. If bending over for a long period of time, stand upright, place your hand on your lower back, bend backward slowly, and come back to upright position. It will make you feel better. Stretching exercises. Before doing any exercises, check with your physician if you have any problem or not. So sit or stand with arms hanging loosely at your sides. Turn head to one side, then to the other. Hold for 5 seconds each side and repeat 1 to 3 times. Stretching exercises also. Stand or sit and place right hand on left elbow. With left hand, pull right elbow across chest toward left shoulder and hold 10 to 15 minutes. Repeat on other side. Stretching exercises also for the trunk. Keep knees slightly flexed. Stand or sit with arms overhead. Hold elbow with hand of opposite arm. Pull elbow behind head gently as you slowly lean to side until mild stretch is left. Hold 10 to 15 seconds. Repeat on other side. Equipment to use. So you have for the bed, the ceiling lift, total mechanical lift, sit and stand lift, transfer belt, non-friction device or air assistive device, assisted devices, cane, wheelchair, etc. Here's some pictures about the different equipment. We have the draw sheet. the gait belts, the Barton chair, as you can see here, it's adjustable. HoverTech hover mat, it's an inflatable mattress. Also the HoverTech hover jack, it's for the transfer from the floor or from lower level to a higher level. Higher lift, as you can see, the slippery Sally roller slide board, the Maxi Move, also to just to transfer the patient from bed to the trolley. Maxi Move, it can help patient to stand up and to bearing weight and to walk with bare weight. Overhead sailing lift. A sailing lift here is a stationary patient lifting device mounted on a rail system, either permanently installed or as a freestanding lift that hydraulically lifts and transfers patient in a sling seat between a bed and a chair, or between a bed and a toilet, or bed, toilet and wheelchair. Also, you have this standing, sit to stand. Also, the HoverTech sit to stand device. Also, you have the Sara Plus sit to stand, and is a standing and raising aid for short transfer here. So you can do some short transfers, raising from bed and transfer to wheelchair, or from wheelchair to toilet. Also a transfer aid for short transfers. Plastic liner slip resistant sheet to just do the rotation. Draw sheet with handles, also to handle the patient or to do the rotation. So as primary evaluation studies here, we have some 13 studies examined multiple best practice program elements. Overhead lifts is long-term care facilities were most effective at reducing the risk of injuries. So the overhead lift in long-term care facilities is the most effective at reducing the risk of injuries. The combination or mechanical lift equipment and training was most effective at reducing injuries and lost work days in the hospital setting. Refresher training improves, sustains adoption of safe patient handling practice. So always we should have training. Some studies found also the use of algorithm to guide staff in deciding which transferring and or lifting methods to use were effective. The primary evaluation studies too, so lift teams were not effective as the only methods for addressing patient handling requirement. Nursing staff did not want to wait for a lift team member to show up to do the task. Adoption of safe patient handling practice, what research tells us, prior studies have reported promising results of reduction of patient handling injuries when patient handling equipment was used. Regardless of outcome, all of the studies reported that barriers in the work process hindered adoption of patient handling equipment use. Barriers to equipment use and other best practice, lack of knowledge on how to use equipment, so training is a must, infrequent training, poor accessibility of equipment, lack of perceived need, lack of time to use equipment, lack of staff to assist with patient move transfers, lack of motivation and the part of staff, lack of policy, no lift, minimal lift, and rapid changing patient population disrupts implementation of intervention programs. And finally, patient may act negatively towards it. For example, here, equipment and overhead supply cabinet not shown are locked to prevent items from disappearing. So if we want, or if we need to use this device, it's locked. So we should find the director or find the responsible person to the responsible person to ask him for the key, etc., etc. So it's a barrier. Also, if you what you can see here, it's the equipment is inaccessible due to the mess here. Okay, we cannot access the equipment to use it. Nursing and healthcare providers culture, patient handling is a part of the job. So hands-on care is a valued part of the job. New nurses want to fit in, should fit in, and social pressure to get job done quickly. As a summary, healthy care workers have very high injuries rates due to musculoskeletal disorder caused by the overexertion of patient handling. Always use proper body mechanics if you have to handle a patient and get help if necessary. Use a patient lifting device where possible and where is practical. Use a lifting team in the event the patient is very large or overly obese. Never put yourself in a position where you and your patient could be injured if you move, lift the patient incorrectly. I would like to finish my presentation with this. A bad system will defeat a good person every time. So try to have a good system and to have a good person. Thank you so much. Do you have any question? Okay. Thank you so much. So we will go for 5 minutes breaks, and we'll be back with Dr. Antoine for the next session. Thank you so much. So 5 minutes and we will be back.
Hello, everyone. Can you see my slides? Okay. Okay, so today we will talk about education for patients post cardiac procedures. We will discuss the three most commonly performed cardiac procedures, which are coronary angiography or angioplasty, PCI, percutaneous coronary intervention, and coronary artery bypass graft surgery, so surgical interventions, and transcatheter aortic valve replacement, TAVR procedure. So we have two invasive procedure, which are PCI and TAVR, but they are not surgical procedures. So there's no anesthesia, there's no general anesthesia. We only give local anesthesia for our patients. And we have a more invasive and major surgery, which is coronary artery bypass graft surgery that's required for sure general anesthesia, and the surgery will take about 4 to 6 hours on average. Coronary angiography and PCI, it depends if the procedure is normal, it can take just 15 minutes, and it can range from 15 minutes to 1 hour or 2 hours if the revascularization is complex. TAVR as well doesn't take as much as the open heart surgery. So we'll start by coronary angioplasty and stenting. So this is the cath lab. You can see we have the patient on the table. The patient is fully awake and can see the screen and can look at the procedure when we perform it. We have the camera that will emit the X-ray beam in order to visualize the arteries on the screen. And we have the doctor, which was the interventional cardiologist that will perform the procedure. And we have the cath lab technicians that will also assist during the procedure. And we have the three screens. We have two screens to visualize the arteries, and we have the monitor in order to check for patient vital signs during the procedure. And it's done in a sterile environment, so everyone is sterile, so it's free of infection. So we need to explain to the patient exactly how we will do the procedure. So first we need to explain to him the point of access. So we have two choices, either the radial access to do the procedure, or the femoral access. So the radial access, we palpate, I will explain to him that we will palpate the radial artery either on the right or on the left. If we prefer to start on the right side. And when we palpate the radial artery, we will put our catheter, we will put the catheter inside the artery, and the catheter will go up in the radial arteries and in the rest of the arteries in order to reach the aorta, then to reach the coronary arteries. Before, we used to do a lot of femoral access, especially in the early 2000s. We used to do only femoral access, but later on, in the last 15 years, radial artery is the mostly used procedure in 95% of cases. We just do femoral access when we can't pass by the radial artery, or if the patient doesn't have a radial pulse, or if the arteries are very small, so we can't introduce our catheter, and we can't move the catheter inside the artery. So in that case, we move to the femoral access. But we have to explain to the patient very well that femoral access has a higher risk, of complications post-procedure, because it has high risk of bleeding, so we can have retroperitoneal bleeding, and it's very hard to control. Unlike the radial artery, if a bleeding or hematoma occurs, we can just compress the area and the bleeding will stop and the hematoma will not progress. But if we dissect the femoral artery during the procedure, it will be very difficult to control the blood, because the femoral artery is deeper than the radial artery. So even if we do compressions, even for more than 15 to 20 minutes compression on the puncture site, sometimes it's very difficult to control the bleeding, and femoral access can lead to mortality if the bleeding wasn't treated. So we need to explain this to the patient before we start the procedure, but we need to tell him that we will try to access by radial artery approach first, but if we fail, we will have to do it by femoral access. Can you see the video?
Procedure is on.
Okay. So I will repeat it. So I will show you how the procedure is done. So this is the coronary artery angioplasty done by the radial axis. This is the beating heart. So we do the procedure under a beating heart. There is no anesthesia. It's unlike the open heart surgery. You see here the coronary arteries. We need to reach the coronary arteries in order to put the stent. And this is the lesion. This is a very severe lesion. It's a 90% coronary artery lesion. So it's a very significant lesion, and we need to treat this by putting a stent. So here is the radial axis, the radial artery. We need to do a radial artery puncture, and when we have blood coming out of this device, we will insert our guide wire. And we insert this dilator in order to dilate the puncture site, in order to insert after that. So this is the guide wire. We insert the guide wire inside the arteries, and we make it move in order to reach this is subclavian artery, and this is ascending aorta. And after that, we put it. This is the catheter. So we introduce the catheter as well. And when we reach the coronary artery, we inject the dye. So we remove the guide wire, and then we inject the dye from the catheter. So now we intubated the left main artery in the heart, and we inject contrast. And you can see the lesion. We have the lesion here. This is the blockage. And we introduce a small guide wire to the vessel, to the coronary artery, and we put a balloon or a stent, and then we inflate. We have to inflate the balloon or the stent. As you can see, we inflate the balloon of the stent. And after that, we remove the material, and you can see that the artery as dilated. This was the balloon. After that, we have to introduce our stent. So first of all, we dilate by the balloon, and then we have to insert the stent inside the lesion in order to prevent the restenosis. So now we dilate it with the balloon, and then we put the stent on the same location. So we put pressure to inflate the stent from the outside, and the stent will stay inside the vessel. We need to explain all these steps to the patient before starting the procedure, and the patient has to sign that he accepts to do this procedure. Okay, so after finishing the procedure, now we put the stent and we started him on antiplatelet medications for 1 year. We need to explain a lot of things to the patient for the next period after leaving the hospital. So rule number 1, we need to insist on him that he has to take his medications like prescribed. So he needs to take his blood thinners, so aspirin and clopidogrel, for example, or aspirin or ticagrelor. He needs to take double antiplatelets for a minimum period of 6 months to 1 year. Usually it's still 1 year in the guidelines. Unless there's high risk of bleeding, we put double antiplatelets therapy for 6 months. He needs to take his anti-cholesterol medicines. So even if the cholesterol level for this patient is low, he has to be on cholesterol because he has atherosclerosis in his coronaries. So he needs to stay on high dose cholesterol for life. And we should insist that the patient should not stop or miss any medication at any cost, because if the patient skips his antiplatelet medication, for example, there's a high risk of coronary, there's high risk of stent thrombosis. So there's high risk of myocardial infarction again. On the stent will be occluded. So the patient has to take his medication like prescribed. Rule number 2, a lot of patients after putting the stent, they think that they are cured and they are free of disease. So they start modifying their diet and going back to the old habits, like eating high cholesterol diet, high fat diet, high sugar diet. So we need to make sure that patient doesn't come back to their previous diet and to stick to their modified diet that was implemented after putting the stent. So for sure, the diet has to be low in cholesterol, low in fat, and low in salt. For every coronary patient, the diet should be low fat, low salt, and if he's diabetic, it has to be low sugar. Even if he's not diabetic, we should limit sugar intake. So rule number 2 is to stick to the modified diet, and the patient should not come back to the previous diet. Rule number 3, always patients will ask us after doing this procedure, they will ask us if they can resume their physical activity. We need to tell them that for sure they can resume the physical activity the next day after the procedure. So if you put the stent today, the next day the patient can move out of bed and can start walking, even if we do it by femoral access. So femoral access, even if we do it by femoral access, the patient can start to do his regular activities the next day, but the patient should avoid heavy activities like weightlifting and climbing and, for example, running a lot for like 4 to 6 weeks after stent placement, because we need to reduce the risk of stent restenosis or stent thrombosis. So we need to allow the patient to do his regular activity 24 hours after the procedure, but he has to be careful with heavy activities. So it's preferable not to do heavy activities for like 4 to 6 weeks. Rule number 4 now is that we should insist on the patient as well to, even if he has any kind of symptoms, he should inform his doctor because of the risk of stent thrombosis after the procedure. There is a risk, for example, like a small percentage of patients will have stent restenosis and will have chest pain reoccurrence after the procedure. So if the patient feels any type of chest pain or excessive sweating or excessive stomach gas, for example, or lightheadedness, the patient in that case should inform his doctor and his cardiologist and his family members as well. So it's very important to educate patient for that. Now, moving to rule number 5. So we need also to tell the patient that he has to come back to his doctor for checkups post-stenting, because the doctor needs to check the diet, needs to check the medicines, if the patient is taking his drugs correctly, and to suggest further investigation, for example, measuring his blood sugar, measuring his lipids, and do echocardiography, for example, if we suspect heart failure. So we need to check, we need to have checkup schedules directly after the procedures, and on, for example, every 6 months, this patient should come back to his doctor in order to monitor all what we said. So to summarize, post-coronary stenting, we need to, rule number 1, check if the patient and inform the patient that he has to adhere to his medication. We need to tell him that he need to have a diet that is good for him and not high in fat. We need to tell him that he can resume his physical activity directly the next day after stenting, but he needs to limit his heavy activities for 4 to 6 weeks. And he needs to inform us if he has any chest symptoms or cardiac-related symptoms, and he needs to come back to his regular checkups after the procedure. Now we move to coronary artery bypass graft. So coronary artery bypass graft is also a procedure that helps us treat coronary artery disease, but sometimes we are not able to do stenting because we have, for example, a very proximal disease, like disease affecting the left main coronary artery, as you see in the picture on the left. So here we have a proximal left main stenosis. Now in the new guidelines, and if the patient is not at high risk, we can put a stent. So even if we have left main lesion, we can stent this artery. But sometimes we do a coronary artery bypass graft due to the proximity of the lesion. And if we have 3 vessel disease, especially in patients with diabetes, we generally do a coronary artery bypass graft in order to limit the number of stents, because if we increase the number of stents, there is increased risk of stent restenosis or stent thrombosis and new myocardial infarction. So it's better in polyvascular disease to do open heart surgery instead of PCI procedure. So we need to explain this to the patient as well, why we are doing this procedure and why we prefer to do this procedure instead of doing a less invasive procedure like angioplasty. So we need to explain to him exactly what we're thinking, and we need to discuss between the patient and the cardiologist and the intervention cardiologist and the cardiac surgeon in order to take the decision. We need to take the decision with the patient. So as we said, this procedure is an alternative cardiac intervention when stenting or ballooning and medical treatment are not successful or are not possible, like in the case of multiple vessel disease. So we need to define the location of the blockages before we do the procedure and the number of the blockages, and tell the surgeon exactly where to put his grafts. So this procedure, we see a video on the next slide. It will help create new routes for blood flow to reach affected areas of the heart, so to prevent further damage and preserving heart function. So I will show you a video. Can you see it?
Bypass graft procedure.
And are you able to hear the voice inside the video or not?
We'll review information about the off-pump cabbage procedure.
Okay.
Before we talk
Great.
about this procedure, let's review some information about your body and your medical condition. The heart is in the middle of the chest, under the ribs. It is protected by the sternum, also called the breastbone. The heart is a muscle that pumps blood to all parts of the body through blood vessels called arteries. Veins are vessels that carry blood back to the heart. The aorta is the largest artery in the body. Two vessels that branch off from the aorta are the right and left coronary arteries. They supply the heart muscle with the oxygen-rich blood that is necessary to keep it working. Coronary arteries can become blocked by plaque, fat, and calcium deposits that build up over years. The result is coronary artery disease, also called heart disease. Severe blockages cause chest pain, heart attacks, and sometimes death. During a cabbage procedure, new pathways called bypasses are put in place to carry blood past and around blockages. Healthier blood vessels from other sites in the body are used to create each bypass. A section of leg vein or piece of an artery from an arm may be removed and used to create the bypass. These transplanted vessels are called grafts. The right and left internal thoracic arteries are also commonly used as grafts. These arteries naturally pass close to the heart. When creating a bypass with one of these vessels, often only one end of the vessel is moved to the coronary artery past the blockage. When arteries or veins are moved or removed from one body part to another, this is possible only when there will still be enough blood supplied from other nearby vessels. There are two methods for doing coronary artery bypass surgery: on-pump and off-pump. To help you understand the off-pump method, let's discuss what it means to be on-pump. During the several hours it takes to do an on-pump cabbage surgery, the heart is stopped for about 30 to 90 minutes. This keeps the heart muscle still while the surgeon sews vessels into place to create the necessary bypasses. While the heart is stopped, a special pump called a heart-lung machine keeps blood oxygenated and flowing through the body. Blood is carried from the body through tubing to a machine where it is mixed with oxygen, then pumped back to the body. After all of the grafts have been placed, the heart is restarted and the pump is disconnected. During an off-pump procedure, the heart is not stopped. Instead, special tools steady areas of the heart while the surgeon stitches grafts into place. The pads and arms of the tool brace the moving heart muscle to hold small sections still. A heart-lung machine is kept on standby during off-pump surgery. The pump can be necessary to help manage some situations during surgery. Individual surgical treatment decisions depend on many factors, including the experience of the surgeon, how many arteries are involved, the location of the blockages, and their severity. Now let's look closer at the off-pump coronary artery bypass surgery. You will be given medication to be pain-free and asleep during this procedure. The necessary grafts are created by surgically removing sections of blood vessel from the leg and/or arm as needed. These incisions are sutured and bandaged. To reach the heart, the surgeon makes an incision down the center of the chest. The sternum bone is carefully cut. A retractor is then placed to hold the edges apart, creating a working area. The protective sac that surrounds the heart, called the pericardium, is opened. The surgeon inspects the heart and identifies the vessels to be bypassed. The intended grafts are stitched into place as needed to complete the necessary bypasses. Blood flow through the grafts is checked. The pericardium is positioned back over the heart. Flexible drains are placed, and the sternum is closed and supported with wire or small plates and screws. The remaining tissue layers are brought together. The skin is closed and a dressing is placed.
So this is a procedure in details, how we do it. We need to explain everything to the patient before the procedure. So we need to explain him that we will put a vessel graft. As we said, the vessel grafts can be an artery. This is the left internal mammary artery. It can also be a vein that we can take it from the lower limbs, or we can take the radial artery in order to bypass the stenosis. And we need to explain him that the procedure will be done under open chest, and sometimes the heart will have to stop in order to be able to work, and then we need to restart the heart after the procedure. So as we said in the video, we take the vein from the lower limb, for example, and we put the vein from the aorta, as you see here, and we put it to reach the coronary vessel, and we bypass the lesion that is here. And we can see the regions of obstructed coronary artery. So this is a venous graft that will act like an artery in order to let the blood flow from the aorta to the region after the stenosis, in order to the blood to reach the distality and to reach the myocardium. So here we have arterial grafts. For example, we have the internal mammary artery graft that we can see. It's the same procedure, but we can use different types of grafts. We need to explain this to the patient as well. So when the patient comes back to the cardiac care unit or the CSU unit after the procedure, the patient will have most of the time a central line inserted. Usually it's on the right jugular vein area, and the patient will have a mid-sternal incision, like we said, because it's an open heart surgery. Sometimes we can have chest tubes inserted in order to remove the excessive blood that was left around the heart and in the surgical area. The chest will be covered by a dressing, a long dressing. We can have, if we remove the femoral vein, so we'll have leg incisions, and also we'll have dressings on the legs. If we remove the radial artery, we'll have right upper limb incision with also a dressing. Can have bruising to the wrist as well, and we can have edema in hand and lower extremity, because, as you know, during the procedure, when we stop the heart from pumping, or we can have some kind of heart failure, and fluid will accumulate in lower limbs and lungs and in the upper limbs. So this is very normal after the procedure. This also should be explained to the patient before we come to the procedure. So now, after the procedure, so when the patient wakes up and is extubated and off sedation, patient should be put on a chair if possible at day one to eat his meals. So we need to put him on a chair 3 times a day. So day one after surgery, we need to put him on a chair in order to take his meals. And we need to start ambulating him. So we need to ambulate him 4 to 6 times in the hospital. So he needs to walk around 100 feet to 100 feet per every time. So 4 to 6 times a day. And the nurse or the doctor should evaluate his walking ability prior to surgery. It's very important to evaluate patient ability prior to surgery, because if a patient, for example, can't walk, we can't classify this patient as a high risk, because immobility after surgery is also a risk to develop a lot of complication. So we need to offer him naps in the morning and in the afternoon, and we need to monitor his intake and output every shift, because intake and output will tell us if the patient is going into heart failure or not. So if the intake is a lot higher than the output, so the urine output is low, so the patient is not able to eliminate the fluids that we are giving him. So this patient is at risk of developing volume overload and pulmonary edema. So we need to do accurate intake output if we can every 1 hour, if we have the required number of nurses. So the patient should be in an intensive care unit. So every patient should have his own nurse, his own staff that is taking care of him. We need to also encourage incentive spirometer. So intensive spirometer is the device we give to the patient in order to inhale and exhale. So the patient should use this device for 1 to 2 hours and do a 10 deep inspirations in order to prevent for sure a lung atelectasis and lung infection and pneumonia. So it's post-op, we can have a lot of lung infections and atelectasis, which is a collapse of a part of the lung that is due to immobilization and anesthesia and the inability to remove secretions post-op. So this device will help patient remove his secretion and prevent the development of infections. We need to reinforce external precautions. So we need to tell the staff that is taking care of the patient that we need to do daily dressings and daily disinfecting the area, because of the risk of developing infection, and the infection in the wound and area is very complicated to treat. And sometimes we need to reopen the chest, and it's a very complicated procedure. We need also to put the patient on systematic medications for pain, because the patient for sure after an open heart surgery, unlike the coronary angioplasty PCI we saw, will have a lot of pain. So we need to put him on systemic pains medication, not on PRN medication. So we need to make sure that the patient is on accurate pain meds in order to prevent his pain. And we need to monitor his blood sugar, because uncontrolled diabetes after surgery is also a high risk to develop infections, to develop complications. And we need to have emotional support for the patient and for the caregiver. So it's very important to avoid any psychological distress for the patient in order to accelerate the healing process. So the first walk, we should be with the patient in his first walk. So the first walk, we said it's the next day. So next day or 44 hours later, we need to be next to the patient, and we need to check if he's able to walk and explain to him the steps that we will do later on. So we need to promote activity. We need to tell the patient that he has to move after the surgery, because a lot of times the patient will be resistant to the surgery because of fatigue, because of depression, because of anxiety. We just need to tell him that the patient will most of the time tell us that I had surgery mindset, so I need to rest because of pain and because of fatigue. Sometimes because of heart rhythm issues, because of the tachycardia post-op, because it's very common to have atrial fibrillation post-op. And but we need to tell the patient that the risk of not walking post-op, because it increases the risk of clot formation. So immobility after operation can increase the risk of deep venous thrombosis, for example, increase the risk of pneumonia and atelectasis. As we said, it will cause muscle wasting, decrease strength, so it will make the recovery even harder, and it will take a lot more time as compared to the patient that ambulates directly after operation. It can alter his mood and cause anxiety, depression, It can delay wound healing. It can increase the risk of infection, as we said. So it's a systemic process. He needs to work in order to prevent all this complication. And we need to discuss all this with the patient to explain him why he should walk. Otherwise, the patient will be resistant and he won't accept. He prefers to stay in bed. So how we can do this? We need to tell him that when we see him walk, we need to encourage him. We need to tell him, great job, for example. We need to tell him, I can tell you, you have been working hard on your lungs, so it sounds great. We need to tell him that you have increased your distance from being admitted, so you're able now to work more. We can put heart stickers, for example, to track walks of the day. We put him for a schedule for him. We need to praise them, tell them thank you for sitting in the chair for 30 minutes. We need to so we need to know how to talk to patients, because this is very important in the recovery process, and we will work on the psychological side of recovery. So we need also to establish pain control, as we said, and encourage pillow use at night. And we need to have good night's sleep in order for the patient to be able to walk the next day. So we need to rest at night. So the ambulation benefits will improve muscle strength, decrease emotional distress, less fatigue, increase in endurance, better prepared to return home or at pre-surgery level, decrease the risk of clot formation, because immobility, as you said, can cause deep venous thrombosis post-op, and decrease the risk of atelectasis and pneumonia. So when you walk, you will be able to eliminate the secretions. So eliminating the secretion will reduce the risk of pneumonia and atelectasis. So now we need to encourage small frequent meals, because, as you know, a lot of patients post-op, they tend to stop eating or decrease because of decrease of appetite. Especially in old patients after age of 60, they will report decrease of appetite post-surgery, and because diminished sense of taste and nausea when they smell food. So we need to tell this, we need to explain to the patients the risk of not eating, the risk of malnutrition, the risk of muscle wasting, the risk of infection, the risk of incision healing time, and constipation, because malnutrition will cause the decrease in proteins secretion in the body. So we'll have a poor wound healing, because we need all the nutrients from food to promote wound healing. So we need to explain this. So we need to explain, so as we said, small but frequent meals. So we need to divide the meals to multiple proportions a day. The diet has to be a high protein meal, and we need to consider proteins supplementary drinks as if the patient is unable to eat. So we need to put him on supplements as well, and add fruits and vegetables aid to bowel motility, because post-op as well, and due to the anesthesia as well, some patients can have decrease in bowel mobility and constipation. So we need to add fibers, because fibers will help us treat constipation. Now we need to, as we said before, we need to monitor the intake and the output for the patient, because these patients are at increased risk of developing heart failure. So we need to check everything that we are giving to the patients, like the perfusion, the medications, and we need to calculate that in order to have a total intake. So for example, we can have a total intake, for example, of 1.5 liters or to 2 liters. We need to check his urine output. The urine output should be around 0.5 milliliter per kilogram per day. So if a patient has a weight of 80 kilograms, he needs to do 40 milliliter of urine per hour. And we need to calculate his urine output over 24 hours to see if the intake and the output are near equal, or we prefer that the output is a bit higher than the intake, because these patients should not be overloaded. They should also always be on the dry side in order to prevent heart failure. So we need to explain this to the patient and explain to him why we are measuring his urine, why he has to collect his urine, because there's no need to put a Foley catheter if the patient can walk. So it's better that the patient collect his urine in order to better quantify his urine output. So this is the incentives parameters that we talked about. I'm sure a lot of you has seen patient using this. So we need to tell the patient he need to do, for example, every 1 hour 10 inspiration in it, and he has to make all the 3 balls go up to reach the top. So this will promote decrease in lung infection and decrease in atelectasis risk. So you need to let him understand why he has to use it, because most of patients will have resistance to use this. They don't like to use it because they say they have pain when taking deep breaths, and they are too weak to take deep breaths. So a lot of patients will say this to us. So when we explain the risk, that there's a risk of pneumonia and there's a risk of atelectasis and lung collapse, the patient then will start to accept, and you can see that he will give more energy in order to let the 3 balls reach the top. So now we move to sternal percussion. So as we said, the patient have sutures on his chest and have dressings. So we need to reinforce sternum stability. We need to tell the patient that this will decrease the risk of infection and decrease the risk of increase the risk of wound healing, because a good wound control will promote wound healing. So we need to tell the patient of the risk. If he doesn't take care of his wound, there's a risk of infection, risk of needing to rewire. Sometimes the wires will drop, so we need to rewire them. The risk of debridement if we have infection in the area, and risk of losing the entire sternum bone and replacement with muscle flap. So if we develop an infection and we have to treat, sometimes we need to remove the sternum bone, especially if the infection, so it becomes an osteomyelitis, so infection reaching the bones, and it's a very complicated condition. We need to avoid this. So we have to explain him, and we can give him visuals like the videos I showed you. Sometimes we need to show such videos to patients in order to let them better explain. So because visual memory is a lot important than vocal memory. So the patient will understand a lot when we let him see the images. So now move on to pain medications. We need to give pain for every patient post-op in order to prevent pain. We need to give pain medication. So pain is completely subjective and multidimensional phenomenon. So every patient can sense the pain differently. So that's why we have to put a protocol of pain medication for every patient. And after that, we can decrease progressively the protocol. And we need to explain the risk to the patient that if we don't treat his pain, there's a risk of anxiety and fear and irritability. This will cause him to stay in bed, to stop eating, and this will cause atelectasis if he doesn't walk, and it causes decrease in wound healing. So pain control is very important for open heart surgery patients. So now we move to the diet and the blood sugar. So it's very important. It's a big effect on patient ability to heal and prevent infection and achieve the best possible outcomes. Why there's a risk of infection if the blood sugar is high? Because as you know, bacteria use sugar in order to produce its own energy. There's a lot, so when you have increase in sugar, there's increase of risk of bacterial proliferation and bacterial infection. So we need to strictly control the blood sugar pre-op and post-op. So the risk is, we need to explain the risk of uncontrolled sugar to the patient. So there's increased risk of mortality and morbidity, and increase in risk of wound infection due to the hyperglycemia, increase the hospital stay, and decrease long-term survival. So a good control of diabetes is very essential for these patients. Now we need to examine the patient and do a daily physical exam, or multiple times a day. We need to check the color. If the patient is pale, so we need to suspect anemia. We need to check his blood pressure, his heart rate, his saturation, his edema, because we said there's a risk of developing heart failure. We need to check the peripheral pulses, if they have warm or cold feet, if he has signs of shock. And we need to notify the surgeon if the patient has abnormal lab results. So if he has paler coloration, if the blood pressure is high or is low, if the heart rate is above 150. So usually when the heart rate is above 150 in a cardiac surgery patient, it's usually an atrial fibrillation because we manipulated the myocardial tissue. So there's a risk of developing atrial fibrillation. If there's persisting fatigue, we also have to suspect anemia due to blood loss during OR. If the saturation is less than 90, we have to suspect lung infection due to atelectasis. Edema in the extremity, we need to notify the doctor because we suspect heart failure, for example. And if we have numbness in arms or legs, so we need to suspect a stroke, so we need to call the doctor directly. Weight gain as well is a sign of heart failure post-op due to fluid accumulation in the body. So now we also need to examine the lungs to check the saturation, to check the breathing pattern, to check if the patient has cough, if he has a lot of mucus. If we hear lung wheezes, so we have a lot of secretions. We hear crackles, so we have a lung infection. And if we doesn't hear sounds, so we most likely have pleural effusion because of heart failure. So physical exam is very important, and we need to explain for the patient why we are examining him multiple times a day. So we notify the doctor if the saturation drops, so we suspect infection, heart failure, or atelectasis, if he has dyspnea, if he has secretions, if you have changing in physical examination, if he's febrile, so infection is suspected. Atelectasis can also cause fever due to inflammation of the area. Coughing up blood, so because patients will be on antiplatelet drug, so they might have bloody secretions. And we need to notify the doctor if the patient has a lot of uncontrolled pain. So same for the incisions, we need to examine the incision to look for drainage, to check wound healing, to see if we have redness, so we suspect infection. Tenderness also is a sign of infection, especially if tenderness is increasing and not decreasing. And we need to check for the stability of the sternum, because the sternum we need to check this because it's a very important bone of the chest, and it will help in respiration. So we need to tell the doctor when we have redness or we have secretion, odors. So when we suspect infection, we have to directly call the surgeon and inform him about this condition. So as we said, emotions is also very important in the healing process, because about 20 to 40% of people will have depression or anxiety post coronary artery bypass graft. For sure, these patients are predisposed to have depression, so they have genetic predisposition, or they have environmental factors that predispose them to developing depression. So we need to monitor sadness. We need to monitor for insomnia, or for feeling guilt or feeling worthlessness. Sometimes the patient will tell us that I want to die. So all these signs are signs of major depressive disorder. So we need to always reassure the patient and tell them as much as we can that all what's happening is normal post this major surgery. And we need to if we suspect confusion or if we suspect depression, we also have to check for his urine infection, because urine infection, especially in old patients, can cause a lot of neurologic symptoms like confusion, like anxiety. So it can cause a lot of atypical symptoms. Sometimes the patient will not report any dysuria or any urinary symptoms, but he will start to have confusions without explanation. So we need to rule out a urinary tract infection, especially in old patients, because as you know, all these patients has a Foley catheter inserted during surgery and the day after surgery. So there's a risk to develop nosocomial urinary tract infection, so infection acquired in the hospital. So now we move to the last procedure, which is transaortic valve replacement, TAVR. So transaortic valve replacement is we can change the valve transcutaneously. So it's also done without a lot of anesthesia, without opening the chest. So we can now change the valve by going through the femoral artery and reaching the heart, reaching the aortic valve, and then we can deploy the percutaneous valve. So I will show you a video to better explain the procedure. So it's a relatively new technique. We are starting doing it with the last few years, and it helped us a lot, especially with old patients and frail patients. So patients that can't tolerate open heart surgery and have severe aortic valve disease. So if the patient has severe aortic valve disease with symptoms, it's an indication to replace the valve. There's two ways to replace the valve. Either we do open heart surgery, so we open the chest, we replace the valve. This procedure is very long and very complicated. Or we have a second type of procedure, which is called transaortic valve replacement, TAVR or TAVI. Sometimes we use it. It's a percutaneous procedure done without opening the chest.
If you have a severe problem
Are
with
you
the
hearing
aortic
the
valve
audio?
in your heart,
Are you able to hear the audio in the video?
and you can't have open heart surgery, your doctor may recommend a transcatheter aortic valve in your
Okay,
a
I will
severe
repeat it.
problem. If you have a severe problem with the aortic valve in your heart and you can't have open heart surgery, your doctor may recommend a transcatheter aortic valve implantation. Your aortic valve is one of the 4 valves in your heart. It lies between your left ventricle or lower left chamber and the large blood vessel supplying oxygen-rich blood to your body, called the aorta. When your left ventricle contracts during each heartbeat, it pushes blood through 3 flexible cup-like leaflets that make up your aortic valve. When your left ventricle relaxes, your aortic valve closes to prevent blood from flowing back into your left ventricle. As you get older, your aortic valve may develop deposits of calcium that cause your leaflets to get thicker and less flexible. In this condition, your leaflets may not open fully. This condition, called calcific aortic valve stenosis, creates a narrowed opening that reduces the amount of blood flowing into your aorta and out to your body. The narrowed valve opening strains your heart because it has to pump harder to move enough oxygen-rich blood to your body. At the beginning of your procedure, your doctor will make a small incision in your groin. After creating an opening in a blood vessel called the femoral artery, your doctor will insert a flexible tube called an introducer sheath. Through the sheath, your doctor will insert a flexible guide wire into your femoral artery. The guide wire will be passed through your femoral artery all the way up to your aorta. Then, the guide wire will be pushed through the opening in your aortic valve and into your left ventricle. Your doctor will use the guide wire to pass a flexible tube called a catheter through your aortic valve. A balloon on the tip of the catheter will be inflated to widen the opening in your aortic valve and push the valve leaflets to the sides. After deflating the balloon, your doctor will remove the catheter. The replacement valve consists of a tissue valve surrounded by a wire mesh called a stent. The replacement valve will be compressed and placed on the tip of another catheter. This catheter will be inserted through your aortic valve. When the catheter reaches the opening in your aortic valve, your surgeon will inflate a balloon underneath the replacement valve to expand it and the stent. After placement of the new aortic valve, your surgeon will deflate the balloon. The stent will support and secure the replacement valve in place. The catheter and guide wire will be removed. At the end of your procedure, the introducer sheath in your groin will be removed. Your skin incision will be closed with stitches. You will have another incision on the other side of your groin, through which instruments were inserted to monitor your heart during the procedure. This skin incision will be closed in a similar manner.
So as you can see, it's a lot less invasive than doing an open heart surgery, and it just require we are now changing the valve with just local anesthesia. So it's a very new technique, and we are now using it a lot more, even for patients that are not very old and patients that are low risk for surgery. But we are seeing very good results with TAVR valves and transcutaneous valve, because we are having every year new studies confirming that this valve can last for a long time. So as you can see here, the aortic valve is a 3-leaflet valve. So it's composed of 3 leaflets. As you can see on the normal valve, closed valve, we have the right We have the left coronary cusp, we have the right coronary cusp, and the non-coronary cusp. So when the valve opens, it's a normal valve. You can see here the valve opens normally and it has a long diameter. But when the valve becomes very calcified and stenotic, you can see that the opening is a lot less than the opening of the normal valve. So this is aortic stenosis, and we use TAVR or surgical aortic valve replacement to treat this condition called aortic stenosis. Aortic stenosis is a single heart valve stenosis. So it's indicated to do surgery when we have symptoms associated with severe aortic valve stenosis, or when we have severe aortic valve stenosis without symptoms, but with a drop of ejection fraction of the left ventricle. So these are class 1 recommendation from the American Heart Association to replace the valve, either surgically or transcutaneously by TAVR. Severe stenosis will decrease the cardiac output. As we said, the EF will drop, so the patient will start reporting lightheadedness, syncope, and fatigue at rest. Syncope in an old patient should always let us suspect aortic valve stenosis, because when the valve becomes stenotic, the cardiac output will drop, so less blood will reach the brain, so the patient will have syncope and will lose consciousness. We can also have CHF symptoms because of the backflow of the blood. When the valve is closed and stenotic, the blood will not be able to go to the aorta and will stay in the lungs, so we'll have congestive heart failure, shortness of breath at minimal activity. So surgical valve replacement is an open chest traditional surgical approach. It's usually usually done when the patient also has associated coronary artery disease. So we do the cabbage procedure and the valve replacement procedure. And it takes a lot longer time to recover as compared to TAVR procedure, and it requires ICU care post-op. So the patient can't go to the floor. It requires ICU or cardiac care unit post-op. And the patient who cannot take blood thinners long-term, for example, they can't take aspirin because of risk of bleeding. So we need to do surgical replacement because TAVR will have to take aspirin. So transcatheter route TAVR valves. So as we said in the show in this video, we need to use femoral access and a large bore sheath catheter in order to introduce the material inside the aorta and inside the to enable to pass through the aortic valve and to reach the left ventricle. So we can have a lot of bleeding precautions. Same for the PCI procedure in the femoral area, because here we are using larger materials. So there's increased risk of bleeding due to usage also of anticoagulation. And we have here, as compared to TAVR, we have fast recovery. So TAVR, just a few days, the patient will recover and doesn't need ICU admission. Now we are able to discharge the patient the next day. So on day 1 post-op, the patient will have a new valve. We change his valve and he can leave the hospital the second day. So it's a very fast recovery, and we need to do echocardiography assessment prior to discharge to make sure that the valve is functioning well. So when the patient comes up from the procedure, we need to do immediate 12-lead ECG. Why we do ECG? Because there's a risk of atrioventricular block, so AV block, and left bundle branch block, because the valve will be inflated just above the electrical conducting system over the sternum. So it's a very high risk procedure of to have AV block post procedure. And when we have complete heart block post procedure, we need to put a permanent pacemaker. So it's very frequent to have pacemaker post TAVR procedure. We need to also do a neurologic assessment every 15 minutes, so 4 times per hour, because also after the procedure, as you know, the old valve was very calcified. That's why it was stenotic. So when we put a stent inside this valve, we have increased risk of calcium to move away from the valve and go to the systemic circulation and go to the brain. So there's a high risk of stroke. So we need to do a neuro exam every 15 minutes to assess the sign of stroke. We need to measure the blood pressure like we do for any patient. We need to tell the patient that he needs to stay at bed for 6 hours. We need to put him on pain medication if needed, and we need to use post-op blood thinners per os So we can give clopidogrel, for example, Plavix. So after the phase 1, so phase 2, we need to prepare the patient to recover and to be discharged. So we need to focus on blood pressure control. We need to tell the patient he need to take his medication like he used to do before. We need to tell him to report us if there's sign of fever, chills, or malaise, because the valve can be complicated by an infection or an endocarditis, so the patient can have fever. We need to teach him that he can have bleeding from his groin on this axis site, and he needs to keep the incision clean and dry. We need to tell him that there's a risk to develop stroke even a few days after the procedure. So we need to teach him what are the signs of stroke. We need to tell him that he needs to avoid heavy lifting. So he needs to exercise. So 3 to 6 weeks after the procedure, he can start to exercise and do sports. So pain medication as prescribed, and we need to let him have a healthy diet. So we need to explain everything to the patient. So the signs of stroke, we have the fast mnemonic, so facial droop, arm weakness, slurred speech, and brain is time. So we need to tell the patient that he can have these 3 symptoms. So if he has these symptoms, he need to come to the emergency department urgently. So aortic valve stenosis is common. It's 1 in 8 Americans have some degree of aortic stenosis, and we're doing around 182,000 surgeries a year to treat this aortic stenosis. So all these patients has severe AS. That's why we proceed with surgery. So we need to tell the patient that if he has signs of stroke, he needs to call the emergency, so 911. He needs to call 911 immediately if he has any sign of stroke, like we said. If he has any signs of chest pain, shortness of breath, so we need to suspect heart failure. Also, he needs to call the emergency department and go to the emergency room. We need also to tell him here he needs to call the doctor, not directly going to the emergency room if he have any fever. So fever above 38 degrees Celsius or 100.5 degrees Fahrenheit is a sign to tell the patient that he needs to call the doctor, because as we said, this can be caused by endocarditis of the replaced valve. So we need to tell him that he can have drainage as well, or swelling in the legs, indicating heart failure, weight gain also indicating heart failure, trouble urinating also can be due to heart failure or to urinary tract infection. So all these signs should notify the patient to call his doctor. At home, the patient should check his temperature every morning. So every morning, the patient should check his temperature, check his weight, check his heart rate, and check his blood pressure. And we need to educate the patient on the normal values of blood pressure, heart rate, and temperature. And we need to educate him that any increase in weight post-procedure is also a sign that the patient needs to contact his doctor. Driving, there's specific instructions for driving depending on the patient age, patient conditions, and a lot of factors. For example, we need to avoid driving if the patient is on pain medications, because pain medication can cause somnolence and the patient can sleep while driving. And the patient should not return to work until he comes to his doctor for a follow-up visit. So after that, if the doctor sees that the patient is able to work, the patient can resume working normally. So activities, they need to walk every day. So they can climb the stairs. They can divide their activities. So if they feel fatigued, or they can spread the activity during the day. And they need to use incentive spirometer at least 4 times a day. So do 10 breaths each time they use it. The diet should be a low-fat diet, maximum of 2 grams of salt, and they need to decrease salt intake, decrease sugar intake. So they need to have a healthy diet to prevent the complications. And for the procedure site, we need to tell the patient that he doesn't need to put so the puncture site on the groins, he doesn't need to put any lotions, ointment, or powders on this area. And any signs of infection should, like redness, swelling, increased pain, should notify him to tell his doctor. And if he has pain, he needs to take just paracetamol or acetaminophen. We need to use pain medications. and he needs to have time to nap every day. So rest is very important part of his recovery. So as for emotions, we need to focus on this. If the patient feels depressed or anxious, we need to send him to a psychiatrist or a psychologist in order to help him recover. The medication instruction, we should print the prescription, put the drug name, if he needs to use it per os or cream, for example, how many times a day, and we need to put the correct dosages in order to prevent any medical errors that will cause a lot of complications. And we need to inform the patient that he is not allowed to take any medication without informing the doctor, and he needs to stick to the prescription prescribed by the doctor and keep the prescription with him every time. So the patient should go to the TAVR clinic, so about 1 month after the procedure. And after that, every 6 months, the patient can see the GP or the family doctor, so the primary care physician. And we need to give the patient a card. So every time the patient go to the dentist, the patient needs to show the dentist this card that he needs to take antibiotics prophylactic before any dental procedure, especially cleaning procedures or procedures that removal of when we remove his teeth, for example, the dentist should prescribe antibiotics to prevent the development of endocarditis. So endocarditis is very lethal condition, especially when it occurs on TAVR valves. So we need to make sure that the patient knows this and the dentist knows this to prevent endocarditis. And thank you. If you have any questions, please let me know.
Okay, thank you, Dr. Antoine. We're gonna start directly with the next session about rehabilitation of the post-cardiac surgery stroke patient. Can you just stop sharing your screen so I can share mine? Okay, thank you. We're gonna move directly to the next session about the post-cardiac surgery stroke patient, so rehabilitation of the stroke patient after cardiac surgery. So first of all, we're gonna start with some statistics. So are you hearing me well? الصوت واضح؟ Okay. Okay, thank you. So every 40 seconds, someone in the United States has a heart attack. Every year, about 790,000 Americans have a heart attack. Just we are taking America just for an example. So about 695,000 people in the United States have a stroke each year. So stroke is the 5th leading cause of death in the United States. So the leading causes of death is the heart disease, as you know, then the cancer, accident, then the chronic lower respiration disease, and for the stroke is the 5th leading cause of death. And then we have the Alzheimer, diabetes, influenza, etc. We're gonna start with a scenario, and I'm gonna ask you to interact with me a little bit. So you are visiting your 65-year-old aunt on your off day, and she is known healthy with a history of some dyslipidemia, maintained on medication. While making some coffee, she all of a sudden became confused, lost her balance. She couldn't clearly talk and explain what is happening with her. So you sat her down and gave her some cold water, which she couldn't even swallow. What do you think is happening, and how are you, how as a healthcare provider going to help your beloved one? So what is the problem here? So she has 65 years, and she's healthy with a history of some dyslipidemia, maintained on medication, and all of a sudden become confused and lost her balance, couldn't clearly talk. Even she cannot swallow the water. So we are talking here for sure about the acute stroke. So what about the acute stroke management? So stroke definition and so stroke is a neurological deficit attributed to an acute focal injury of the central nervous system by a vascular cause. Cerebral infection, intracerebral hemorrhage or bleeding, and subarachnoid hemorrhage, and major cause of disability and death worldwide. The transient ischemic attack, TIA, are sometimes known as warning strokes. It's important to know what a TIA is. So TIA is a warning sign of a future stroke. And TIA is a medical emergency for sure, just like a major stroke. So there is no way to know in the beginning whether symptoms are from TIA or from major type of stroke, like ischemic stroke or blood clot often cause TIA. There is the two type of stroke, as you know. There is a ischemic stroke and the hemorrhagic stroke. As per the ischemic stroke, most stroke are ischemic usually, and ischemic stroke occurs when blood clots or other particles block the blood vessel to the brain. So fatty deposit called plaque can also cause blockage by building up in the blood vessel. So that's what we call ischemic stroke. As per the hemorrhagic stroke, happens when an artery in the brain leaks blood or rupture. So the leaked blood puts too much pressure on brain cells, which damage them, and the high blood pressure and aneurysm balloons like bulges in an artery that can stretch and burst. So this is the hemorrhage, and you have the rupture of the vessel. So for the ischemic stroke, it's 87% almost, and for the hemorrhagic, it's 30% of the total of stroke. As per clinical presentation, patient can feel headache or confusion or abnormal vision or abnormal speech, weakness, numbness on one side of the body, loss of balance, and inability to walk. And that is what the famous word FAST, F-A-S-T, for sure you know about it. So F is for face, when you have the drop face or dropping face, and A it's for R, when we have weakness in one of the R, speech when we have S for speech, so when we have difficulty in speaking, and for sure the T is for time. And here what we say, it's good to say time is brain. So it's very important to take the patient as soon as you can to the emergency room. So to do the assessment, we have the Cincinnati pre-hospital stroke scale. So this scale is a system used to diagnose a potential stroke in a pre-hospital setting. So it tests 3 signs mainly for abnormal finding, which may indicate that the patient is having a stroke. If any one of these 3 tests shows abnormal finding, the patient may be having a stroke and should be transported to a hospital as soon as possible. The first one is the facial drop. Have the person smile or ask him to smile or show his a teeth. So if one side doesn't move, one side of the face doesn't move, as well as the other, so it seems to drop, that could be a sign of stroke. The normal is both sides of face move equally. The abnormal is one side of the face does not move as well as the other. The second sign is the arm drift. So in this phase or sign, we ask the person to close his or his eyes and hold his arms straight out in front with palms facing up for about 10 seconds. If one arm does not move or one arm ends up drifting down more than the other, that could be a sign of stroke. So the normal position is both arms move equally or not at all. The abnormal, one arm does not move or one arm drift down compared with the other side. The third sign is the speech. Have the person say or ask the person to say, for example, you can teach an old dog new tricks, or you can ask him to say his name, or to ask him to say which date or month or time or something. So or some familiar saying, familiar word. So if the person slurs the word, gets some word wrong, or is unable to speak, that could be a sign of stroke. So normally, patient uses correct words with no slurring. Abnormal, slurred or inappropriate words or mute. He can say nothing. So if patient with one of these 3 findings as a new event have 72% probability of an ischemic stroke. If all, it means the 3 signs finding are present, the probability of an acute stroke is more than 85%. So patient should be transferred directly to the emergency. So as I said before, time is brain. So in a typical acute ischemic stroke, every minute until reperfusion of the brain loss, 1.9 million neuron, 40 billion synapses, and 7.5 miles myelinated fibers. So we have to save it by time. Save all of this by time. So we have the Ds of stroke care. So the Ds of stroke care are of number 8. So we have 8 Ds of stroke care. So first one is the detection. It's the rapid recognition of stroke symptoms. So here we have the detection. It involves rapid recognition of stroke symptoms. So early symptoms of a stroke include, for example, weakness or numbness, as I said, numbness of the face or the arm or leg, especially in one side of the body. So, and also we have other signs and symptoms, for example, confusion, dysphagia or aphasia, difficulty with seeing and or, for example, walking, dizziness, and severe sudden headache with a which is non-identified. As per the dispatch, it's an early activation and dispatch of EMSS by calling the emergency. So dispatch involves early activation of emergency medical services. Half of all stroke patients are driven to the emergency department by family or friend. This prevents the emergency department from being ready to receive the patient and having the proper providers and system and make the system ready for treatment. So medical dispatch should be thoroughly trained to identify a possible stroke patient so that the appropriate level of EMS services can be dispatched to the patient. And moving to the delivery, so rapid EMS identification, management, and transfer. So here we have the delivery. So it's the prompt transport of the patient to a hospital, and it's preferably to a stroke center. So emergency medical person should be trained in performing a rapid assessment of the patient condition. If a stroke is suspected, here the patient should be transported to an appropriate hospital as soon as possible. And a medical history and baseline mental status should be documented. The time since onset of symptoms should also be noted and is referred to as time 0, or the last time the patient was seen to be normal. So emergency medical workers need to provide pre-arrival information to the receiving facility so that the emergency department can prepare for the arrival of the stroke patient. As per the door, it means it's the appropriate triage to stroke center. So door refers to the arrival of the patient to the emergency department. So the stroke team should be in a place at the receiving facility prior to the patient arrival to ensure prompt assessment and diagnosis. According to recommendation, an assessment should be completed by a emergency department physician within 10 minutes of the patient arrival in the emergency department. So here about the data. So data collection is a vital component of the chain of survival. So a CT scan is an essential tool needed for an acute diagnosis. Sometimes a non-contrast CT scan should be performed to differentiate ischemic stroke from hemorrhagic stroke. So the CT scan should be completed within 25 minutes of the patient arriving to the emergency department, and should be read within 45 minutes of arrival in the emergency. So time is really very important. We don't have the, if you want, the leisure of having all the time. So decision, the 6D, so it's a stroke expertise and therapy selection. So in this phase, regarding the type of treatment needed is the next step in caring for a patient with a stroke. So information such as the type of stroke that has occurred and the time from onset of symptoms is considered before a treatment decision is made. the severity here of the stroke may also play a role in deciding what the most appropriate treatment will be. So the patient and family members should also be informed of the risk and benefits of treatment options. Moving to the drug and device, so fibrinolytic therapy, intra-arterial strategies. So this drug administrations, if for sure, if appropriate, is the next link to the chain of survival. So if the patient is a candidate of this kind of therapy, fibrinolytic therapy, so the window of opportunity for administration is narrow. So according to the American Heart Association guidelines, fibrinolytic therapy should be administered within 3 hours of the onset of symptoms. So if the patient is not a candidate of drug therapy, they may qualify for endovascular therapy to remove the clot mechanically rather than with fibrinolytic. As per the last one, the disposition, in this step, the step in stroke, so rapid admission to stroke unit ICU. So in this step, stroke care focus on the continuing care of the stroke patient. It's recommended that patient be admitted to an intensive care unit or stroke unit within 3 hours of arrival in the emergency department. We should continue monitoring and care of a stroke patient, includes frequent assessment of neurological status and monitoring of glucose level and the vitals, as well as if there is some complication, so to prevent the complication. Here in this slide, you can see the suspect stroke algorithm. Starting with identify signs and symptoms of possible stroke activate emergency response. In this level, we should observe the patient for signs of a stroke, as I said before. So use FAST, the face, arm, speech, and time, to remember the warning sign, which, as I told you before, facial dropping, arm weakness, speech difficulties, and time. So at this phase, we should so observe the patient and call the emergency. The second phase in this algorithm is critical EMS assessment and action. At this level, we should support ABCs giving the patient oxygen if needed. So, and perform a pre-hospital stroke assessment. Determine the time of stroke onset and triage the patient to a stroke center. And alerting the hospital in advance so they can activate and be ready and activate the stroke team. The third level, immediate general assessment and stabilization. At this level, once the patient has arrived at the emergency department, and within 10 minutes of arrival, we should assess the vitals, providing oxygen if the patient is hypoxemic, and obtain the IV access, run labs, check glucose, activate the stroke team, and perform neurologic screening with emergent CT scan or MRI of the brain. As per the first level, immediate neurologic assessment, a stroke team or design. So within 25 minutes of arrival at the emergency department, the stroke team should review the patient history, should establish a timeline of symptoms onset, and perform a neurologic examination using the NIH stroke scale or the other neurological scale. The step 5 here, which is the CT scan, here to know if the CT scan show a hemorrhage or not. So determine whether or not the CT scan shows hemorrhage within 45 minutes of the patient's arrival, at the emergency department. Then we can go to probable acute ischemic stroke. So consider fibrinolytic therapy. If the CT scan shows no sign of hemorrhage, it's probably that the patient experienced an ischemic stroke and is a candidate of fibrinolytic therapy. So check for fibrinolytic exclusion for such a, for example, significant head trauma or stroke in the previous 3 months, history of cranial hemorrhage, elevated blood pressure, active internal bleeding, etc. So we should repeat the neurologic exam. Then we should go to consult the neurologist or a neurosurgeon. So after probable acute ischemic stroke, consider the therapy. If there is hemorrhage, we should consult a neurologist or a neurosurgeon. And then we go to administer aspirin. Here it's very important and we should be aware. If the patient is not a candidate of fibrinolytic therapy, administer aspirin and being the stroke or hemorrhage pathway. So patient remain candidate for fibrinolytic therapy. We should go to review risk benefits with patient and family if acceptable. And finally, we should begin post the RTPA stroke pathway. Begin the post-RTPA stroke pathway within 3 hours of patient arrival to the emergency department. Admit the patient into the stroke unit or intensive care unit. Here's this is a Bartel scale index. One of the scale, it's an ordinal scale used to measure performance in activities of daily living. So we have 10 variables describing activity of daily living, and mobility are scored. So it's a higher number. So the higher number being a reflection of greater ability to function independently following the hospital discharge. And so time taking and physical assistance required to perform each item are used in determining the assigned value of each item. So the Bartel index measures the degree of assistance required by an individual on 10 items of mobility and self-care ADL. So the population, if you want, the target population of this scale is patient with stroke, neuromuscular or muscular skeletal disorder, oncology patient, etc. Method of use, time of administered self-report is 2 to 5 minutes. Direct observation is 20 minutes. Time may vary depending on client tolerance and abilities. So it requires training if administered by direct observation. The Bartel index includes 10 personal activities, which is feeding, as you can see, personal toileting, bathing, dressing and undressing, getting on and off a toilet, controlling bladder, controlling bowel, moving from wheelchair to bed and returning, walking on level surface, and ascending and descending stairs. So, as you know, each item is rated in terms of whether the patient can perform the task independently with some assistance or is dependent on help based on observation. So 0 means unable, 1 means that he needs help, and 2, it means independent. And if the score is between 21, for example, between 0 and 20, indicate total dependency. So if it's low, and the score going higher, it means there is a severe dependency if it's between 21 and 60, It's moderate between 61 and 90, moderate dependency, and between 91 and 99 indicates slight dependency. What about the TPA for stroke? So the TPA is a tissue plasminogen activator for acute ischemic stroke. It's a activator or a strong clot dissolving medicine. Stroke occurs when an area of the brain, as I said before, is deprived of oxygen and nutrient because of a blocked blood vessel. Many sudden blockage are due to blood clot. It can result in loss of function in the affected area of the brain for sure. So common signs and symptoms of stroke include abrupt onset of one-sided weakness, numbness, and difficulty with vision, speaking, thinking, or coordination. So stroke mimic is a term used for medical problem that can present in a manner similar to stroke. As per the potential benefit, so the National Institute of Neurological Disorder and Stroke study suggested that 8 out of 18 stroke patients who receive TPA according to a strict protocol will recover by 3 months after the event without significant disability. This is compared to 6 out of 18 stroke patients who recover substantially regardless of treatment. As per the potential risk, as with must treatment, so there are risks associated with TPA administration. Studies vary in predicting the likelihood of complication, which include bleeding into the brain, other type of serious bleeding, gastrointestinal, for example, and death. Some research, for example, the NINDS study suggested that bleeding into the brain occurred in about 1 out of 18 patients receiving TPA. So specifically 5.8%. When this occurred, there was a 45% fatality rate. Several studies here suggested treatment with clot dissolving medication increases the number of patients who die following a stroke. Also, there are subsequent studies demonstrated that using TPA more liberally than is recommended in the NINDS protocol resulted in a higher rate of intracranial hemorrhage. So complications are more likely when TPA is used in patients over 70 years old, those with more severe stroke, or those with glucose over 300 milligrams. Moving to the balancing benefits and risk and alternative, it's important for physicians and for patients also and family members to weigh the possibility of benefits against the possibility of harm. So stroke symptoms alone are insufficient to definitely diagnose stroke and in patient with a stroke mimic. So TPA use results only in potential adverse effects without any possibility of benefits. So here we can say the alternative treatment with proven benefits for patients with stroke include like aspirin and care in a specialized unit where staff members pay careful attention to a variety of basic aspects of care. So here, as we said before, so we have the medical ischemic fibrinolytic agent RTPA should be administered between maximum 3 hours to 4.5 hours. Contraindication of the TPA and the exclusion criteria and the relative exclusion criteria. So there is a in 2016 2016, there is an update was published by the American Heart Association to guide the TPA inclusion and exclusion criteria for the management of ischemic stroke. So the following list includes the most recent absolute and relative contradiction for therapy as determined by the American Heart Association. So the exclusion criteria are the significant head trauma or prior stroke in the previous 3 months. Also, the symptoms suggest subarachnoid hemorrhage, arterial puncture, history of previous intracranial hemorrhage, intracranial neoplasm, aneurysm, recent intracranial or intraspinal surgery, elevated blood pressure, more than 185 over 110. Active internal bleeding, acute bleeding diathesis, platelet count less than 100,000, current use of anticoagulant, current use of direct thrombin inhibitors, blood glucose concentration less than 15, and CT or demonstrated multi-lobar infraction, hypodensity greater than 1/3 cerebral hemisphere. There is also a relative exclusion criteria. So recent experience suggests that under some circumstances, with careful consideration and weighing of risk to benefit, patient may receive fibrinolytic therapy despite one or more relative contradiction. So consider the risk of to the benefits of intravenous RTPA administration carefully if any of these relative contradictions are present, which are only minor or quickly improving stroke symptoms, pregnancy, seizure at the onset with postictal residual neurological impairment, major surgery or serious trauma within prior 14 days, excuse me, and recent gastrointestinal or urinary tract hemorrhage, and a recent acute myocardial infarction within the last 2 to 3 months. Okay. So patient, here's some studies and data. So patient treated with intravenous TPA within the first 60 minutes of their stroke onset, the putative golden hours had significantly better outcome at hospital discharge compared with patient treated just an hour later based on US data from more than 65,000 acute ischemic stroke patients. Also, in national US clinical practice, treatment with intravenous TPA in the golden hour, so the first 60 minutes, compared with later, is associated with more frequent independent ambulation at discharge, discharge to home, and freedom from disability or dependence at discharge compared with patients treated at 61 to 180 minutes, according to researchers. Here there is the NINDS TPA stroke trial, excellent outcome at 3 months on all scales. So as you can see, so 52%, the yellow one is the treated with TPA, and the blue one is a placebo. So as you can see, for the Bartle index, we have 52% for the TPA and 38% for the placebo. As per the Rankin scale, 43% for the TPA and 26% for the placebo. Glasgow outcome and NIHSS score also the same, 45% and 35% for the TPA, 31% and 21% for the placebo. So researchers of a multivariate analysis examining treatment outcome using intravenous TPA quickly from their stroke onset found that even a 30-minute drop in the time to treatment produced substantively better outcomes. So the percentage of patients with a modified Rankin score of 0-1 at discharge was 38% in the 0 to 60 minutes patient, and 33% in those treated after 91 minutes to 120 minutes, and 28% in those treated 121 minutes to 180 minutes after symptoms onset. Moving to the endovascular technique. So how does the procedure work, why perform it, and what are the risks? The endovascular treatment of stroke is the non-surgical treatment for the sudden loss of brain function due to blood clot, as you know. So the treatment uses microcatheter, which are inserted into the blood clot from the groin or the arm. So the blood clot is removed from the blood vessel. This procedure is called thrombectomy. If the blood clot cannot be removed, it's liquefied using drugs delivered through the catheter in a procedure known as thrombolysis. So how does the procedure work? The interventional radiologist will insert a catheter into an artery in the arm or the groin and move it towards the blood clot under X-ray guidance. So the blood clot is removed in a procedure called, as I said, thrombectomy. The blood clot may be removed by trapping it in a stent, which it is a stent which is pulled out with the clot, or the interventional radiologist may suck the clot out throughout the catheter. Why we perform it? If patient have suffered stroke caused by a blockage in a large artery, but he's not suitable for or have not responded to thrombolysis, this procedure is a possible treatment. And what are the risks? The insertion of catheter and guide wires in arteries to the brain carries a low risk of bleeding or the movement of blood clots to previously unaffected parts of the brain. So endovascular treatment is inadvisable if the admission to the hospital after the stroke was delayed, and this carries a higher risk of complication. Okay, we have some quiz here. If you can just answer this quiz. So patients treated with intravenous tissue plasminogen activator, so TPA, within the first 30, 60, or 120 minutes of their stroke onset had significantly better outcome at hospital discharge compared with patients who were treated later, according to data of acute ischemic stroke patients. Okay, so someone is telling me 30, so it's the first 60 minutes. Okay, so it's the first 60 minutes. Yes. So patient treated with intravenous, as I said, TPA within the first 60 minutes of their stroke onset, we call it golden hour, had significantly better outcomes at hospital discharge compared with the patient treated just an hour later. And it's based on US data, as I said before, from more than 65,000 acute ischemic stroke patients. Quiz number 2. Yes, time is break. So treatment with intravenous tissue plasminogen activator in the first 60 minutes is associated with more frequent independent ambulation at discharge, discharge to home, and freedom from disability or dependence at discharge compared with patient treated at 61 to 90 minutes, 61 to 120 minutes, 61 to 180 minutes, and 120 to 180 minutes. Which one is correct? 61 to 120, 120 to 180. Okay, okay. So it's 61 to 180 minutes. As per the national US clinical practice, the treatment with intravenous TPA in the golden hour compared with later is associated with more frequent independent ambulation at discharge. So discharge to home and freedom from disability or dependence at discharge compared with patients treated at 61 to 180 minutes, according to researchers. So moving to the quiz number 3, patient treated with intravenous with TPA in the first 60 minutes of their stroke onset was linked with 1% of relative increase in being non-disabled at hospital discharge. So 56, 72, or 80%. Okay, Fatima is saying 72. There is another question, answer 56. Najla is saying 3. Okay, so it's 72%. As I said before, in a multivariate analysis that adjusts for many potential confounders, treatment with TPA in the first 60 minutes of a patient's stroke onset was linked with statistically significant improvement compared with patient treated at 1 to 4.5 hours for several outcomes. Including a 72% relative increase in being non-disabled, a modified ranking score of 0. The last one, researchers found that even a 30 minutes drop in the time to intravenous tissue plasminogen, so TPA treatment for patients, produced substantively better outcomes. So the percentage of patients with a modified ranking score of 0 to 1 at discharge was 24, 38, or 56% in the 0 to 60 minutes patient compared to those treated 91 to 120 minutes after, or 121 to 180 minutes after stroke onset. Do you remember? So, okay, you said 56, 38. Okay, you said 38. Okay, yeah. So it's 38%. So as I said, so the percentage of patients with a modified ranking score, it's 38%. Stroke, here we're gonna see the stroke rehabilitation from basic to advanced. Advantage of fitness training, easy administration and relatively low cost possibility of being delivered to groups, clearly established evidence for stroke patients with mild to moderate impairment at both the acute and chronic stages in outcome, and limited scientific evidence here for fitness training to improve quality of life. As per the constraint-induced movement therapy, we have the advantages. So the activities to be trained may be those that are part of the patient's daily lives and be administered within their life context. Clearly established evidence for stroke patient at the acute, subacute, and chronic stages in outcome related to the quantity and quality of the use of their paretic upper limb in daily life. It's a, if you want, a behavioral approach which focuses on improving and increasing the use of the paretic limb in people with asymmetrical use of the limb. Biofeedback, the biofeedback is it's delivered using equipment here to provide patients with information regarding physiological process during the performance of given movement. and given activity or task in order to improve performance and learning. The advantage of the biofeedback, the physiological information is continuously and simultaneously delivered in an objective manner and is specific of the trained movement, activity, or task. For stroke patient at the acute and subacute and chronic stages to improve activity performance more related to the lower limb. As per the limited scientific evidence for sensory motors impairment, activity related to the upper limb and spasticity that interferes with activity or personal care. As per the electrical stimulation, as you know, the electrical stimulation, it refers to the stimulation of an intact lower motor neuron by an electrical current generated. It can be used to activate paralyzed or paretic muscles, aiming at generating muscular contraction, or modulating neural activity to regain voluntary contraction or to prevent abnormal muscular reaction. So the advantage is in precise sequences and the magnitude electrical stimulation can be used to directly accomplish functional tasks. Clearly established evidence for patients at the subacute and chronic stages to improve muscular strength and activity performance. Limited scientific evidence to prevent, clear, or treat swelling of the extremities and to deal with spasticity that interferes with activity or personal care. Progressive resistance training is also a kind of treatment. So it refers to the use of progressive overload applied to a specific muscular group to stimulate further adaptation towards specific training goals. The advantage is low cost, easy to administer, and may be delivered in groups. It can be used for muscles of different segments, upper limb, lower limb, and trunk, and also for the respiratory muscles. Clearly established evidence for weak patients at the acute, subacute, and chronic stages without any adverse effect, even on spasticity, to improve strength and gait performance, quality of life, and oxygen consumption. The limitation, so to improve mobility, sit to stand, stair climb, the performance of activity related to the upper limbs, and functional performance in general. The mirror therapy. As you know, it focuses on moving the unimpaired limb while the patient watches its mirror reflection superimposed over the impaired limb that is unseen. So thus creating a visual illusion of the movement capability on the impaired limb. The advantage of this technique, it's low cost and it easily performed. The patient may perform the intervention by themselves. Clearly evidence for weak patients at the acute, subacute, and chronic stages to improve the following outcome related to the upper limbs, pain, motor function, and the performance of functional activity. The limited evidence to improve range of motion, visual spatial neglect, and the performance of activities of daily living. BOBAT concept, it's defined, as you know, by the International BOBAT Instructor Training Association and as a problem-solving approach for the assessment and treatment of individuals with disturbances of function, movement, and postural control due to a lesion of the central nervous system. So the aims are to identify and analyze problems within functional activities and participation in everyday life, as well as analyze movement. So it's based upon afferent information named facilitation to enable successful movement and task performance. The advantage of this technique, it's a global strategy with a holistic approach, but it requires expert training to be delivered. The evidence, there is no evidence that the BOBAT concept is superior to other approach. Transcranial magnetic stimulation, it's an intervention aiming at altering the stability of the motor cortex. Improvement in motor performance after stroke have been found after inhibiting the unaffected hemisphere, as well as increasing the excitability of the affected hemisphere. The advantage of this technique, it can be implemented for stroke patients with severe motor impairment. Limited evidence is to improve motor recovery at the acute and chronic stages. At the moment, no adverse effects have been reported. The task-specific training technique, it's an intervention aiming at it consists, if you want to, of repetitive training of movement directly related to functional activities. So the advantage of this technique, it can be performed as circuit training and delivered to group. The intensity of training can be adjusted and progressed to fit the individual's need. The evidence, so for stroke patients at the subacute and chronic stages, to improve balance, to improve sit to stand, reaching, manipulation, and to improve walking performance. The mental practice, it's a cognitive strategy in which a brain area related to specific motor action is triggered repeatedly through the activation of the imagination, with the goal of improving the patient performance. The advantage of this technique for many individuals with nervous system damage, the execution of certain movement is very difficult and sometimes even impossible, which hampers their activity participation in the rehabilitation process. In this sense, mental practice allowed the realization of all movement. Limited evidence for this technique of the benefits of mental practice, in addition to other rehabilitation strategies for measures of upper limb function. No adverse effects with stroke patients, the acute, subacute, or chronic stages were observed. Finally, we have the virtual reality therapy, which refers to use of interactive stimulation generated from images, such as computer processors, to provide the user the opportunity to interact with environment that simulate real objects and events. So through a virtual environment rich in details, virtual reality simulate functional tasks that are intensively practiced. Advantage of this technique, so the virtual reality programs simulate real life functional activities, so it's an interesting and challenging manner and may encourage the practice of a higher number of repetitions. So the difficulty of the tasks can be graded, and the physiotherapist can simulate tasks that could not be trained within clinical settings, such as crossing a street, for example. Limited evidence of this technique of the benefits of virtual reality compared with the same doses of conventional rehabilitation strategy for measures of upper limb function and daily life activity. There is limited evidence on the effectiveness of virtual reality in measures of grip strength and gait speed. Okay. Here I'm gonna speak about technology in rehab. So the technology in rehab provide real-time biofeedback, like feel, see, and hear. The objective measures monitor progress, tracking outcomes, evidence to third-party prior, clear to patient, relevant to society, motivating, engaging, stimulating. Also, we have the marketing tools, screening and research, real-life simulation in clinic, errorless learning. Three crucial elements for the acquisition of motor program through rehab: adequate feedback, variability of practice, and design of learning situation. So here's some, I will go quickly with this. So we have the Biodex Balance system. So this is a force platform for testing and training of static and dynamic standing balance. The capabilities fall risk screening and training, postural stability, clinical test of sensory integration of balance, compare scores to age-dependent norms, also charts progress over time, determine which of three balance system patient is relying on. We have also the NeuroMove. So it's also a good device. It's administered to stroke rehab by muscles re-education, relaxation of muscle spasm, prevention of retardation of diffuse atrophy, increase local blood circulation, maintaining or increasing range of motion. How it works: detect attempt below where trace movement are visible. When a real attempt is detected, the unit rewards the patient with muscle contraction. Visual and sensory feedback serves as an important element in relearning the movement. And it's very motivating. See, they could make a difference where previously they had no indication of their attempt. Here we have the Armeo. It's boom spring power. It's suitable for individuals who have suffered stroke, traumatic brain injuries, or neurological disorder resulting in hand and arm impairment. How it does work: adjustable arm support with a highly sensitive hand grip and a video game like exercises to stimulate arm movement used in specific real-life tasks. Exercises are carried out of the virtual environment on a computer screen. Use residual neuromuscular control to perform the exercises and gradually build strength in arm. Built-in sensors and software record arm movement at each joint, so therapists can track improvement, determine the appropriate difficulty level for patient, and customize training program as patient progress. We have also the Locomate. It's a robotic gait orthosis, longer and more intensive training session compared to manual treadmill training, real-time feedback for a higher motivation and compliance. It's a gait asymmetry may be associated with many potential negative issues. Challenges to balance control, increased energy expenditure, increased risk of musculoskeletal injury to the neuropathic lower extremity, and decreased overall activities level. There is evidence, so assumed reduced spasticity, improved walking ability, increased alertness, strengthened leg muscles, and also improved stamina and increased motivation. So severely impaired ambulating stroke patient benefit from the task-oriented and intensive training. Ambulating stroke and locomotor improvement might depend on an early training onset as well as a high number of repetitions. This is this is a kind of treadmill with weight bearing, if you want. This is also another device. It's for the brain injury rehabilitation by muscles re-education and maintain or increase range of motion. How does it work? The arm brace has EMG sensor that sit on the skin surface and detect even a very faint muscle signal. Person with weak or partially paralyzed arm tries to move their arms and a muscle signal fires. So the robotics in the M-Power engage to assist in completing the desired movement. So in helping achieve desired movement, this device can be worn as a functional aid, used during exercise to maintain gains, or applied as a rehabilitation device that reteaches arm movement to the brain. Also, we have the free step supported ambulation, the tibian leg orthosis. This robotic aid that aids the knee inflection and extension, activated by a foot sensor, follow parameters set by the patient, worn during, set by the physical therapist, and worn during therapy session for strengthening and movement retraining. So the benefits of this device: more sit to stand exercises, more overground steps per session, more repetition of stair climbing, increased potential for neuroplasticity. The evidence is to improve gait speed and endurance and balance. The Karen, it's a computer-assisted rehabilitation environment. This is interesting. And the Karen, it's a 21-foot dome, helps researcher analyze how patients react to different walking speed, inclines, and environment. So walking down a busy street, for example, see other pedestrian around. So he's in front of a big screen and he can see all of this. So see the building here and see traffic. I walk in the woods, see the trees, hear the wind and the birds, etc. So computer linked to sensor on the body, move a treadmill to match the ground you'd be walking over and adjust video images all around to what patient would like to see and hear when walking. Can be used with wheelchair also, as you can see here. Okay, this is the machine of the equipment. Okay, this is the references. And I want to thank you so much. It's my last session. I want to thank you for your participation and for your interaction. And I will leave you with Dr. Antoine for the final session to end this symposium. And I hope that the symposium reach your concern and it was it reached your if you want so إن شاء الله يكون هالسيمبوزيوم وصل للإكسبكتيشنز تبعكم. Thank you so much. And I will leave you with Dr. Antoine for the last session. Dr. Antoine, are you ready?
Yes, I'm ready. Can you stop yeah, yes, I will share my screen now. Okay. Can you see the slides?
Yes, it's okay.
Okay. So I will start with the last topic of this series of lectures. It's about the relation between diabetes and cardiac diseases. So how do we diagnose diabetes? So normally, in order to diagnose diabetes, we have a criteria. We need either a fasting blood sugar above 126 milligram per deciliter. So we measure blood sugar before, in the morning before the breakfast. If it's above 126, so it's diabetes. Or we can measure 2 hours postprandial. So after eating, by 2 hours, we can measure blood glucose. If it's above 200 milligrams after a glucose tolerance test, so if we give a glucose to the patient and we measure his blood glucose 2 hours later and it's above 200, it's also diabetes. Or also if we measure a random blood sugar per day, for example, and we find a number of 250, for example, and the patient has symptoms of diabetes. So we have a lot of symptoms of diabetes, like, for example, polydipsia. So the patient drinks a lot of water, or increase in weight, or loss in weight. So all these things will let us think of diabetes. So if a glucose is above 200, it's also diagnostic. And the most accurate one, it's the hemoglobin A1C level that will measure the average glucose concentration in the last 3 months. So if the number is above 6.5%, it's also it can confirm diabetes. But before the development of diabetes, we can have something called pre-diabetes. So it precedes diabetes, and it's characterized by insulin resistance. So in that case, the fasting blood sugar will be between 100 to 125. The normal is less than 100. The 2-hour blood sugar after meals or after glucose tolerance test will be between 140 and 199. and we will have a hemoglobin A1C level between 5.7 to 6.4%. So this can diagnose pre-diabetes. So as we said, hemoglobin A1C, it measures the average blood sugar level over the past 3 months, as we said. Hemoglobin is a part of the red blood cell, which carries oxygen. So when blood sugars are high, hemoglobin joins with the sugar in the bloodstream. That's why we can use hemoglobin in order to have an estimation of the last of the glucose numbers in the last 3 months. It will give us a percentage of blood cells, of red blood cells, that has sugar attached to its hemoglobin. So when we say, for example, 6.5%, it's so 6.5 of the hemoglobins that are found in the red blood cells are attached to sugar molecules. So when the number increases, it means that the concentration of sugar or glucose in the blood is also higher. So we have some sayings before that said that if we eat too much sugar, we will develop diabetes. It's in fact, diabetes is an inability of the pancreas to produce insulin. It's not just related that we are eating a lot of glucose. If a person is able to produce adequate quantity of insulin by the pancreas, they will not develop diabetes even if they eat a lot of sugar. So it's not from eating too much sugar. It's from inability to produce insulin by the beta cells of the pancreas. So why do some people cause diabetes? Why they have inability to secrete insulin? We will see. So we have a lot of genetic predisposition to diabetes and to insulin resistance. So insulin resistance is affecting the pancreas. So beta cells, as we said, are responsible to produce insulin in the normal human. So they will start in the stage of pre-diabetes, they will start to increase insulin production to overcome the resistance. So we have resistance to insulin. So insulin will not be able to reduce glucose level like in normal individuals. So beta cells will first try to compensate by increasing the insulin production. But over time, beta cell will fail because they are overproducing for a long duration, for years. So they will fail at the end, and they will stop producing insulin. And in that stage, we'll have diabetes, and we will have diabetic requiring insulin therapy because we don't have diabetes due to beta cell fails. Okay, so the risk factor to develop type 2 diabetes are like the other risk factor for all cardiovascular diseases: age, so increasing age; ethnicity, African Americans are more prone to develop diabetes; family history, because we said we have genetic predisposition to develop diabetes. So if a mother or a father or a brother or sister have diabetes, we have a higher chance to develop diabetes. Gestational diabetes, so if a female is pregnant and during pregnancy she developed diabetes, we call this gestational diabetes. This is associated as well with the development of diabetes later on in life, even after delivery. A lot of patients will have resolution of diabetes after delivery, but a percentage of patients will continue to have diabetes even after delivering the baby. So overweight as well and obesity are associated with diabetes, like any other, they are the risk factor for all cardiovascular diseases. And low activity status is also a risk factor for diabetes. You can see here that in 1994, we didn't have a lot of obese people, so with BMI of above 30. You can see that we just had 14% to 17.9% in most United States areas. But in 2015, you can see that it's now in dark red color. So we have more than 26% of people with BMI of above 30 kilogram per meter square in most of the states. And you can see that diabetes is also going with obesity. So when obesity is increasing, you can see that diabetes is also increasing. And in 2015, the last prevalence study in the US, it showed that more than 9% of people on average in all the states have diabetes. So it's increasing with the increase in obesity. Okay. So how can we prevent diabetes? So can we prevent it, or it's a disease that will continue to progress? So in fact, healthy lifestyle changes, including diet and exercise, can delay the onset of diabetes in those at risk. So we can delay it, but we cannot stop it. It's very hard to stop diabetes, even if we implement a very healthy diet and very strong exercise program. We can delay the progression. So we delay it for 10, 20 years, but if the patient has predisposition to diabetes and has the genes to develop insulin resistance, he will end up with diabetes. So we need to start at the pre-diabetes stage. So we don't have to wait till the onset of diabetes in order to implement these changes. We need to start at an early stage in order to further delay the diabetes and the complications. You can see here that lifestyle, if initiated early, was better than introducing a medication, which is metformin. So, and both lifestyle and metformin were better than a placebo, so better than not doing anything. And you can see that the cumulative incidence of diabetes was decreased the most in lifestyle modification, even more in when lifestyle was stronger than metformin, because here we're still before the stage of developing diabetes. So lifestyle is here the most important one. So 5 to 10% weight loss reduces development of diabetes by 58% in subject with predisposition to develop diabetes. Okay. So now, if we have diabetes, can we eat carbohydrates? So a lot of patients ask us if they have diabetes, can they still eat some carbohydrates like the normal humans? So in fact, they need to eat the same diet as anyone else. So everyone should eat a diet high in vegetables, fruit, fiber, grains, lean meat, not red meat, and healthy fats, and moderate intensity of sodium and low in saturated fats. So they can take small portions of carbohydrate, but they need to choose complex carbohydrates, not the regular carbohydrates. Okay. So it's very important to educate patient on that topic. So a lot of patients ask us as well if it's better to measure the blood sugar fasting, so in the morning before eating, or they should measure it after eating. In fact, it's better to measure it while fasting, because it will show us how our body is doing where we're not eating for many hours. So all night we will not eat in normal conditions. So if we measure our fasting blood sugar, it will give us a greater indication of diabetes control. And the normal fasting blood sugar should be less than 100 in normal population. But in the case of diabetes, we accept values that reach 135. So we should be between 100 and 135 fasting in case of diabetic patient. And we should be as close as possible to 100 milligram per deciliter. And when we reach this number, we can say that we are controlling our diabetes. Okay, so is there any indication to check the blood sugar after eating? Yes, for sure. Sometimes we ask the patient to measure the blood glucose per eating in order to see the expected rise of our blood sugar post-eating. This is very helpful, especially for patients that are taking insulin, because they sometimes has to take insulin post-meals in order to prevent hyperglycemia. So we can base our numbers on the postprandial glucose, so after eating glucose, in order to adjust the medication dosages. And after 2 hours of eating, for normal patients without diabetes, we should have a glucose of less than 140 milligram per deciliter. In diabetic, we can accept values between 150 to 180 milligram per deciliter 2 hours after eating. But we should be as close as possible to 140. Okay. Okay. So also the patients will ask us if they will end up taking insulin at the end, or they can prevent taking insulin, because a lot of patients are afraid of taking insulin. So we need to tell the patients that generally, if we stick to the diet and to the healthy lifestyle, like exercise daily, for example, and reducing sugar in the diet and eating good carbohydrates, not bad carbohydrates, we can stay on medication per os tablets for 5 to 10 years without requiring insulin. But as time goes by and as with time, the beta cells will fail, as we said, because they were facing a lot of resistance to insulin. So they will increase to the production of insulin initially, but at the end they will fail. So generally, it will take 10 to 15 years since the diagnosis of diabetes to have a complete beta cell failure. And in that case, we will need to start injecting our patients with insulin. We have the long-acting insulin that will last for 24 hours, and usually we give it at night time to cover the 24-hour periods that will follow. Or we can give short-acting insulin, post-meals insulin, in order to try to decrease the glucose concentration after meals. So we have a lot of medications. We will talk only about 3 of these medications because these medications could have a cardiovascular protective effect. So the most common use and initial drug that we use in diabetes is metformin. So metformin will act on it will decrease sugar production by the liver and increase sensitivity to insulin that is produced by the liver. So it has a function to decrease insulin resistance and prevent or delay the beta cell of the pancreas failure. So it's the most commonly used drugs and the first-line drug, still the first-line drug we use in diabetes. The second class of drug we will discuss today are GLP-1 mimetics. So these drugs are subcutaneous drugs, so we inject them subcutaneously. We have 4 drugs. We have the exenatide, liraglutide, albiglutide, and dulaglutide. Liraglutide is used most commonly. So these drugs will help stimulate insulin production in response to a meal. So they act on the satiety pathway. When we have a meal, the body will increase insulin production as induced by this medication. Okay. And we have the SGLT2 inhibitors. These are the revolutionary drug, if we can say, because these drugs will act on the kidneys. We have receptors in the kidneys that are responsible for reabsorption of glucose from the urine to the bloodstream. These medications will inhibit these receptors, so they will inhibit the reabsorption of glucose from the urine. And we have 3 drugs, the canagliflozin, dapagliflozin, and the empagliflozin. These drugs are very, very important because they also reduce cardiovascular mortality by around 30%, even in patients that doesn't have diabetes. So if a patient is non-diabetic and has heart failure, giving them SGLT2 inhibitor will reduce mortality by around 30% as compared to patients not on SGLT2 inhibitors. So it's a drug that acts on multiple systems. It will act on the heart, on the kidneys, and it will improve diabetes as well. And insulin for sure. When we have uncontrolled diabetes on these medications, we have to use insulin. So here is a picture of the renal glucose handling. So you can see the majority of glucose is absorbed here at the level of these receptors. So we have the receptors here, and the SGLT2 drugs inhibitor will act on these locations. You can see that 90% of glucose is absorbed here, but we have also 10% of glucose that's absorbed in the distal part of the renal tubes. So in that place we have SGLT1 receptors, but we don't have drugs to inhibit these receptors yet. We just have drugs to inhibit the SGLT2 receptors, which are responsible for 90% of the glucose reabsorption, while the SGLT1 receptors just are responsible for absorbing only 10% of the glucose. So we have a drug acting on the 90%, which is good. So the end result is minimal to no glucose excretion if we don't use this drug. All the glucose will be reabsorbed. So here is a study that studied one of these SGLT2 inhibitors called empagliflozin in diabetes with cardiovascular disease. It's a study called EMPA-REG outcome trial. you can see that comparing empagliflozin to placebo resulted in a decrease in cardiovascular events in patients taking diabetic and taking empagliflozin. We have decreased all-cause mortality in patients taking empagliflozin as compared to not taking any medication or placebo. And they followed the patient over 2 years, so 48 months, so making this a very significant trial in favor of the usage of empagliflozin in diabetes and cardiovascular disease. Here is the second drug that we talked about, the GLP-1 receptor antagonist. We said that this drug will cause increase in insulin sensitivity and insulin secretion in response to a diet or a fatty meal. So we'll have increase in satiety. So patients also will have increased satiety, so will not ask for food anymore. So that the blood pressure will drop. And this drug also can cause weight loss. So it was one of the few drugs in diabetes that can cause weight loss as well. But we should not prescribe this drug to lose weight. It's not a drug that we should use in order to lose weight. Okay, so we only should use it to increase insulin secretion and increase satiety. So as an end result, we will have a weight loss that will also be a favorable outcome in diabetes. So now, can we prescribe any of these drugs, or there are specific indications to prescribe the drugs? For sure, we have specific indications. So as we said, metformin is the preferred initial drug for treatment. As you know, all patients that are diagnosed with diabetes, first drug to use is metformin. If the glucose is not controlled, or if hemoglobin A1C is very high at diagnosis, we need to use combination drugs. So metformin with a second drugs. If the patient has cardiac disease, cardiovascular disease associated with diabetes, then the second drug should be either SGLT2 inhibitor or GLP-1 antagonist, because we said that these two drugs have cardioprotective effects. So in case of any cardiac events, heart failure, or any other cardiac disease, it's better to combine SGLT2, so empagliflozin, or GLP-1 with metformin in order to reduce cardiovascular disease. We said that we have around 30 to 40% reduction of cardiovascular disease with empagliflozin, in addition to metformin. So here, the slide is about this topic. So empagliflozin is used for cardiovascular disease protection. And in patients without atherosclerotic heart disease, we can use metformin alone in combination with weight loss in order to drop blood sugar. So what are the scary facts? You know that heart disease is the #1 killer of both men and women in the United States. It can kill people more than cancer, heart disease. So heart disease affects people with diabetes at a younger age, because diabetes will have a lot of complications in the vasculature. So they are at risk of developing CAD, coronary artery disease. And this risk increases with the duration of diabetes. So the higher the chance they will develop heart disease, the higher the diabetes was diagnosed. So if more than 10 years, will increase the development of heart disease by 2 to 4 folds. And they have increased the risk to develop peripheral arterial disease. So not only coronary artery disease, we have also peripheral arterial disease. Okay. And so multivessel disease, multi-organ disease, and they have worse prognosis after developing a heart attack. I will show you why, because atherosclerosis is increased in patients with diabetes. You can see in this image that shows the vessels here, you can see the progression of the atherosclerotic plaque and the rupture at the end of the atherosclerotic plaque that will occlude the vessel. And this process is accelerated in the case of diabetes. So diabetes can cause microvascular complications. It can affect the eyes by causing retinopathy, so affecting the retina. It can cause kidney disease by affecting the kidneys, so it will cause nephropathy. It can cause macrovascular complications, so the big vessels like the peripheral arteries, the carotid arteries, and the medium-sized vessel like the coronary arteries. So it can affect all vessels in the system, small vessels, medium vessels, and large vessels like the carotid, the aorta. It can affect the organs like the retina, and it can affect the kidneys mainly. You can see here it's a study published in the United Kingdom. It was a study on diabetic patients in 3,867 patients. So they followed the patients with diabetes to see how much they are developing complications for macrovascular complication and microvascular complication. So they found out that the risk of developing macrovascular, so PAD or CAD or carotid disease, was around 30% after 10 years. So it's a big number. While CAD was found, so medium vessel disease, in 25%, around 25% after 10 years, and CVA, cerebrovascular accident or strokes, have around 7%, while microvascular disease like blindness affecting the retina is less than 5%, and end-stage renal disease, if we are treating diabetes well, so less than 5% in 10 years. So end-stage renal disease will develop later on. So we need more than 10 years. So here is the pathology of atherosclerosis. How I have atherosclerosis in diabetes, because hyperglycemia and insulin resistance with excess free fatty acid will cause oxidative stress. So will cause increased inflammation, and we have a lot of mediators of inflammation like the nitric oxide, the NF-kappa B, the angiotensin, the prostacyclins, the tissue factors. So we have a lot of factors that will contribute to this endothelial dysfunction. So at the end stage, we'll have vasoconstriction, inflammation, and thrombosis. This will lead to the atherosclerosis and the narrowing of the blood vessels. So here is a coronary angiogram. I will put the laser pointer. So this is the left system of the heart. We have the catheter here that we are using to inject the contrast, the iodine contrast. You have the left main coronary artery that will bifurcate, and it will give you the left circumflex artery, which is here with its branches, the marginal branches, and it will give you the left anterior descending artery. This is a normal patient. You see that all his arteries are normal in size without evidence of any stenosis. While diabetics, for more than 10 years, we said there's 25% of developing a coronary artery disease after 10 years. So you can see here we have the vessels are destroyed here. We have lesions everywhere. We have a lesion here, we have a lesion in the left main. So all the left anterior descending artery is full of disease. The left circumflex artery as well, you can see it has lost its shape. So it's full of disease. In that case, we can't do anything. We can't put stents everywhere. We can't do a surgery because the vessels are very small in size as well. So here, the patient is a very high risk of death. So diabetes is a disease affecting the coronary arteries, making them also making for us the very difficult to treat because of the small diameter and the diffuse lesions. Okay, so coronary artery disease, when we have coronary artery disease in diabetes, you have to know that in diabetics, we have decreased neuron sensation. So they will not feel pain as non-diabetics. So every time we see a patient, for example, and coming to the ER with atypical chest pain and has diabetes, we need to suspect a coronary artery disease because diabetics sometimes can't feel pain, or they can feel very atypical chest pain. So we need to have a high degree of suspicion in diabetic, even if they don't report symptoms, or if they report atypical angina, we need to rule out coronary artery disease or myocardial infarction. They can have silent myocardial infarction, so myocardial infarction without chest pain. It's a bit rare, but it can happen, and we most of the time misdiagnose patients with diabetes. So we miss a myocardial infarction. If we miss a myocardial infarction, for sure the patient will be in heart failure and with a reduced ejection fraction. So it will be a very worst outcomes for him. We can have other symptoms. For example, if we have atherosclerosis in the abdominal vessels, we can have abdominal pain. If we have atherosclerosis in the lower limbs, we can have claudication, so the patient will not be able to walk properly. So to prevent diabetes, we need to stop smoking for sure, because smoking is associated with diabetes, and we need to make sure the patient is on a good diet and on a good physical activity trainings, and we need to add metformin and add GLT2 inhibitors to metformin if the patient has cardiovascular disease or if his blood sugar is not controlled with metformin alone and with diet and physical activity. And we can add as well GLP-1 inhibitor if the patient is also not on the target of blood glucose, or if the patient has cardiovascular disease. You can see the commercial names that we use. We have Jardiance for the empagliflozin, and Victoza, it's the most commonly used, is the liraglutide GLP-1 inhibitor. So how to prevent cardiovascular disease? Aspirin, if age above 50. This is not always true because in the newest guidelines, we're not recommending aspirin for everyone. So we see when it's recommended to use aspirin. If the patient has high blood pressure, we need to target his blood pressure to be less than 130/80 millimeter mercury by using drugs that helps in delaying the chronic kidney disease progression, because chronic kidney disease can happen on long term in patients with diabetes due to diabetic nephropathy. So we use ACE inhibitors ACE inhibitor or the drugs that end with pril, so lisinopril, enalapril, so drugs like these, they reduce stroke, MI, and death and CKD. And we can use angiotensin receptor blocker for the drugs that end with sartan, like valsartan, or drugs in the same family. They reduce mortality in diabetes and hypertension and left ventricular hypertrophy, and they delay the progression to CKD. So when to use aspirin as a prevention? So if we use aspirin, we should use aspirin between doses of 75 milligrams to 162 milligrams a day. And we should use it if the patient has a score. So we have an ASCVD score. We will not go into details of this score, but if the score is about 10%, and there is no high risk of bleeding, so there is no recent GI bleeding, there is no peptic ulcer disease, so there is no risk of bleeding, then we can use aspirin in diabetics. And this is class 2A evidence. So it's not class 1, but it's class 2A. It was incorporated in the American Heart Association and American Diabetes Association in 2015. Aspirin also may be used in case of increased cardiovascular disease. So in most men and women with diabetes age above 50 who have at least one additional major risk factor, like family history of premature CAD, hypertension, dyslipidemia, smoking, or albuminuria. So this is also was added to the ADA 2018 guidelines. So we should not use aspirin for everyone. Aspirin increases the risk of bleeding and increases the risk of mortality. So it's not recommended to use aspirin as a protection. A lot of patients use aspirin for prevention. We should stop using aspirin for prevention. We should use it only in specific situations. So when to use statin? Because we said also that diabetic patients at increased risk of CAD. So we have to use statin in order to drop their cholesterol level. So if a patient is diabetic with a history of atherosclerotic cardiovascular disease, so any evidence of atherosclerosis, high-dose statin should be given for everyone. Okay, so if we have cardiovascular disease risk factor, it depends on the age. If the age is between 40 to 75 with a high score of ASCVD, so we can use moderate to high intensity. If the age is if the age is less than 40 and above 70, we can use moderate to high. But if the age is adult between 40 to 75, we have to use high dose statin. So atorvastatin 80 milligrams or 40 milligrams, and or rosuvastatin 20 to 40 milligrams as well. Okay, so we need to have cardiovascular disease risk factor with diabetes in order to use statins. If we don't have risk factors with diabetes, we also use high dose in patients with 40 to 75. So as you can see, nearly in all situations, we need to use a moderate to high dose of statins in diabetics for all age group, except for diabetics that have no other cardiovascular disease risk factor and are less than 40 years of age. Here, we can wait on the usage of statin and wait till the age of 40 to introduce statins. So this is a study. It was published in the Lancet journal. It's an old study, but the results, we're still using its results until now. It's a study called CARDS. it showed that using atorvastatin even at a low dose, so atorvastatin 10 milligram is a low intensity, it's not a high intensity. We said high intensity atorva is 40 to 80 milligrams. So using this dose compared to placebo was associated with a reduction in cardiovascular events. We have a significant reduction of cardiovascular events. You can see that the p-value is 0.001. So there's a significant absolute risk reduction in this population. You can see that the LDL-C was 120 with the placebo on average, and it drops to 81 milligram per deciliter with just 10 milligram of atorvastatin. So for sure, there is a higher benefit if we use higher dosages of atorvastatin, like using 40 milligrams or 80 milligrams. It will significantly decrease the major cardiovascular events. Okay, so we have modifiable risk factor like diabetes, high blood pressure, high cholesterol, smoking. So we have life factors that can increase the diabetes, but we can stop these factors and modify them. But we have also non-modifiable risk factor like genetics. So if we have family history, like age, we can't modify age for sure, like race, we can't modify our sex. Or if we develop, a female develop preeclampsia or gestational diabetes, also we can't modify it. So there's increased risk of developing diabetes at adult age. So it's a major risk factor for heart disease due to atherosclerosis, and the plaque and diabetic, so artery plaques have different morphologies, like the angiogram I showed you. You can see that the arteries of diabetics are very different than the arteries of non-diabetics. Okay, so now the last topic we will discuss is diabetes. So we have the cardiovascular disease. So cardiovascular disease is not just the heart, it's also the vessels. So diabetes can affect the peripheral arterial disease as well. So peripheral artery, especially the artery of the lower extremities. Okay, so there was a study published in the AHA, a guideline on the management of patients with lower extremity peripheral arterial disease. We will use this study in order to discuss our next slides. So I will show you a case. It's a 72-year-old female with type 2 diabetes. She presents to her primary care physician for evaluation of a left leg pain while working. So she mentions that she only can walk about 2 blocks, and after that she has to stop because of her left calf cramping. So the first thing to note here is that her pain is upon walking. So she has to stop to relieve her pain. So pain increasing with activity but decreased with rest, and her pain is unilateral. So it's just affecting one side of her body. She works as a full-time as a housekeeper, so she needs to walk a lot. So she has activities to do. She's diabetic, hypertensive, and has cholesterol. She never smokes. Her father and mother died of heart attacks. So she's a high-risk cardiovascular patient. She had family history. She has diabetes. She has cholesterol. She has age, which is non-modifiable. She is on aspirin for primary prevention because she's as high risk as we said. She's on lisinopril for her hypertension and for diabetes to prevent CKD. She's on atorvastatin because she's at a high risk diabetic and she's a cholesterol patient, and she's on metformin to treat her diabetes. So when we examined her, we found that she has weak pulses on the left foot, so on the foot that has the pain. So here we should suspect arterial disease. So we should suspect ischemia in her limbs. So peripheral vascular disease have a lot of things in common with other vascular disease. So there's PAD has a lot of common with coronary artery disease and a lot of things in common with cardiovascular disease in general. So you can see that these 3 circles interact together. So they are very closely associated with each other. So if we have, for example, CAD, there's a high risk to develop peripheral arterial disease at the same time. So when we diagnose coronary artery disease, we need to also check for peripheral arterial disease, because most of patients with CAD have a high percentage to have PAD and cardiovascular disease in general. You can see that 5-year mortality of PAD is not low, it's quite high. It's quite high. In fact, it's around 30% mortality after the diagnosis of PAD. So here we said that it's about 50% at 10 years. So at 5 years, it's 40 to 30. At 10 years, it's 50% mortality. So it has higher mortality than leukemia, than blood cancer, like hematologic cancers like Hodgkin's lymphoma. Even it has higher mortality than breast cancer. So PAD is not it's a very serious disease and leading to high rate of mortality if left untreated. So here, this study is to show you that race, so black skin African Americans have higher mortality in the male sex. So the mortality after the age of 80 in patients with PAD is around 70% in blacks. While in women, the difference is not that significant. So you can see the black Americans have mortality rates of around the same of American Indians and Asian American and Hispanics and non-Hispanic whites. So you can see that the Hispanics or the whites have the lowest mortality rate in PAD. All these risk factors increase PAD, like they also increase CAD, because we said the two entities will interact together. So smoking, diabetes, hypertension, cholesterol, CRP, so inflammation, will increase the development of peripheral arterial disease over time. So 80% of deaths in diabetic patients are a result of atherosclerosis. So it's either CAD or PAD. This will lead to death. Okay, so there's also a risk to develop PAD. The risk of PAD dramatically is higher in patients with coexisting nephropathy. So they found in the study that developing CKD with diabetes increases the risk of peripheral arterial disease even more than diabetes alone. So this is the mechanism, as we said before. So to summarize it, it's a lot of factors, increase in inflammation, increase in oxidative stress, that will lead to endothelial dysfunction. Endothelial dysfunction will increase the risk of atherosclerosis and vessel narrowing. So we will increase the risk of PAD and CAD at the same time. So here are the patients that are at high risk, so above 65 years, because atherosclerosis increases with age, even if not in non-diabetics. Age 50 to 64 with risk factor for atherosclerosis, like diabetes, smoking, hypertension, hyperlipidemia. Age less than 50 with diabetes and one additional risk factor for atherosclerosis. So we need to have diabetes and another thing to say that this patient is at risk of PAD. So patients with PAD will have a variety of symptoms. So you can see that they can be asymptomatic early on in the disease because it's stage 1 peripheral arterial disease. So we have evidence of PAD on imaging, but the patient does not report symptoms. This is called stage 1. It's asymptomatic. Stage 2 PAD is when we start to have symptoms, but we have just mild claudication. Claudication is when we have to stop after walking, so we can't continue to walk. We need to rest in order to decrease the pain. But there is no limitation in walking. The patient can continue to walk. The symptoms are tolerated. Stage 2A symptoms are moderate claudication, so patient can is able to walk without stopping for 2 blocks, more than 2 blocks, or 200 meters, or 5 minutes in total. So after that, they will stop. This is moderate claudication. As for severe claudication, it's called stage 2B. They need to stop walking in less than 200 meters or in less than 44 minutes. So this is advanced stage. And stage 3 is ischemic rest pain. So patient will have symptoms at rest even without walking. This is very advanced stage, and we need to treat before reaching this stage, because this stage will end up by leading to ulceration. So we will have skin symptoms. You'll see ulcers developing on the skin because of lots of blood supply to this area of the skin, and we'll end up having gangrene. So we'll see images on the next slide. So it's a black discoloration of the peripheral limbs. When we reach this stage, it's usually irreversible stage. We can't, even if we restore blood flow, we will not be able to reverse gangrene. So we need to act before arriving to the stage 4 of symptoms. So here is the history. So as you said, we'll have claudication, and on the physical exam, you can see a decrease in pulses on the affected limb. You can hear vascular bruits when we put the Doppler machine. So we can see ulcers, gangrene developing on the lower limb, and you would see that the limb is becoming pale, so and is becoming cold. So you always need to check the pulse, and you need to check the temperature of the limb and the aspect of the limb. If the limb is pale, if the limb is cold, if the pulse is decreased, this means that we have an ischemic event happening on the vessels on the arteries of the lower limbs. Sorry. So here are the images. You can see that this patient, for example, has cyanosis developing on his extremities. It's due to poor blood supply. And in the picture on the bottom on the right, you can see that we have gangrene. So this is an irreversible stage, and we need to act before the stage in order to prevent it. So here, so we need to rule out both diseases at the same time when we find one of them. So coronary artery disease can be diagnosed by ECG, echo, stress test, or by doing a coronary angiography, while peripheral arterial disease can be diagnosed by a non-invasive test, ankle brachial index. I will show you how to do it. Duplex ultrasound, so we can do imaging, echo, so to diagnose it, or you can do CT scan or MRI or angiography. So we can inject iodine contrast in order to visualize the vessels. So how to calculate the ankle brachial index? Ankle brachial index is calculated by dividing the ankle systolic pressure. So we measure the pressure, as you can see on this image. We measure the pressure on the ankles, and then we measure the pressure in the brachial artery, and we divide. The normal value in normal patient without PAD should be between 1 to 1.4. Why is that? It's because the blood pressure in the lower limbs is usually higher than the blood pressure in the upper limbs. So the ratio is expected to be above 1 because the numerator is higher than the denominator. So ratio is expected to be above 1. If we find a ABI of less than 0.9, in that case, we can diagnose peripheral arterial disease. Why it's less than 0.9? Because now the blood pressure at the level of the ankle is lower than the blood pressure at the level of the brachial systolic pressure, artery, because we have less blood flow reaching the extremities. So for sure, the pressure will drop. So we'll have pressure in the upper extremities that are higher than the pressure on the level of the lower extremities. So it's the opposite case. So to diagnose PAD, we need a ABI, ankle brachial index, of less than 0.9. It's a very sensitive and specific test and non-invasive test, so it's very simple test to do to diagnose. So back to our case, the patient that we already discussed, we said that she has left-sided pain. They calculated her ABI on the left side. She has an ABI of 0.7, which is very reduced. So it's suggestive of peripheral artery disease, and it's very compatible with the symptoms she's describing. While ankle brachial index on the right side was 1.0, so it was normal. She only has ABI on her left side. Okay, so when we suspect PAD, as we said, we need to do an ankle brachial index, but sometimes we have normal ankle brachial index, but we are still suspicious. So sometimes there's exceptions. We can have normal values or near normal values like 0.95, for example. In that case, we need to do imaging. We need to do ultrasound, scan, or MRA. Even if we diagnose PAD, so by ankle brachial is less than 0.9, we need also to do imaging in order to know exactly where the lesion is in order to treat it. So we need to have a vascular surgeon that was to be consulted on the case, and we need a radiologist to do the exams, the rest of the exams as well, in order to know exactly where the disease is. So there's a 73% chance to develop claudication that is stable. So he will still be able to walk, but with pain, but it will not be an advanced claudication in 73%. But in 16%, this stable claudication will progress to reach higher stages. So patients will not be able to walk more than 4 minutes, then he needs to rest in order to relieve his pain. It will require revascularization, so putting a stent or doing a bypass in 7% of cases. And it will reach gangrene stage, so gangrene is treated by amputation in just 4% of cases. And this is because the treatment is very effective in order to prevent this end stage of amputation. So individuals should be advised to stop smoking, so should be advised to use lifestyle medications, lifestyle modification. They should be advised to use statin medications, like the case of coronary artery disease. Any PAD patient should be on statin. They should treat the blood pressure with medication. You should use antiplatelets. So CAD and PAD are treated the same way. So aspirin or clopidogrel. We just use one, like the case of stable angina. So we need just one. It's either aspirin, and this aspirin is not available. If aspirin is not tolerated, we use clopidogrel. We can use also a drug called cilostazol. It's a drug that's effective in decreasing pain and decreasing claudication and increasing walking distance. It's a 1A recommended drug. It acts on the vessels and vasodilation, and they should have supervised exercise training. So they should be able to do 30 to 45 minutes exercise 3 times per week. So here is the, when we stick to these guidelines, so when we do all these guidelines, it's the blue curve. You can see that the major adverse cardiovascular events were lower as compared to using just few of these guidelines. So using all these guidelines in blue has decrease in mortality. Same here, as the second graph shows us some the amputation rates and the major limb events. So it's for sure better when we use all these guidelines. So in the curve, in the blue color. So claudication is the analogy to angina, to the chest pain. When we have claudication, so pain in the extremity, it's the same of having chest pain. It has similar outcomes to having an angina. So there's no urgency to treat claudication, but we need to do more tests in order to see if the patient will benefit from stenting of these femoral arteries. But if the patient has critical limb ischemia, so if have discoloration, absence of pulse, cyanosis, gangrene, this case is considered equivalent to acute coronary syndrome. So here we need to do limb salvage. So we need to have urgent procedure. We need to put the stent urgently, like we do in the case of myocardial infarction and ST elevation myocardial infarction. Here it's a medical emergency to act and put a stent. So patients with critical limb ischemia, so complete occlusion of the artery and the absence of blood flow, will be dead in 20% of cases, even if treated. They will be alive with amputation in 35% of cases, and they will stay alive without amputation. So if we put a stent very rapidly, in 45% of cases. So here is back on our patient. You can see that this is her left arteries, left lower limbs arteries. On the right side, we should have similar image. You can see that the right side became occluded a few months after she presented to the doctor. So she was treated with stenting. She was treated with a lower limb stent, and she regained her blood flow. So the revascularization is still low in multiple areas in this world. You can see it's reflected in the US map. We have areas with low threshold or for revascularization. Patients are left with ischemia without treatment, so increase in death rate. Same for amputation. It varies between regions, so it's very variable. So as a summary, peripheral artery disease is a common manifestation of systemic atherosclerosis. So CAD and PAD are associated, and diabetes is as diabetic patients have higher risk to develop PAD. So 3 to 5 times higher rates to develop PAD than patients without diabetes. And early diagnosis and medical treatment can delay significant disease like ulceration of the limbs and amputations. So diet is very important as well. We discussed this before. So we need to have a balanced diet, vegetables, fruit, We need to limit red meat. We need to increase in good carbohydrates, so not the chocolates or the food high in sugar. We need to add fibers, grains, as we said, and use the few types of meat can help, but not that all types of meats can help. So the red meat is harmful for this type of patient. Chicken breast with skin on is also not to be used. Pork belly and bacon also increase the risk of these patients. So should limit red meats, and they should limit saturated fat, and they can use unsaturated fat, which are good, like olive oil, nuts, avocado, fatty fish, and seeds. All these contain high rate of unsaturated fat, which is a good fat. And they need to limit the sodium usage, so less than 2.5 gram per day, and ideally less than 1.5 gram per day of sodium. And we should be aware of, because sometimes they don't add sodium to the diet. The sodium is, for example, in pizzas or in chicken, we have already high sodium concentration in these types of food, so they should limit adding sodium to the food as well. And this should be the plate for diabetic and vascular patients. And they should have weight loss, and activity should be recommended. They should have at least 2 hours and 30 minutes of moderate intensity aerobic activity every week. So they should have supervised programs. They need to consult a coach, for example, in order to put a program, and a dietitian in order to arrange their diets. We has to work with dietitians in order to have better outcomes for our patients. So doctors should not be responsible for the diet. We need to send the patient to a specialist. And this is a wrap-up or a summary of everything we said about the diet and the exercise. And by this, I think we end this lecture. And if you have any questions, I'm ready to answer. And I hope you learned from these sessions 4 days. And I really enjoyed giving them. So I hope you really enjoyed too and learned from these sessions. So thank you for listening to us. And if you have any question, you can ask us for sure.
Thank you, Dr. Antoine. Thank you, everyone.
Thank you.
It was really a pleasure, and hope we'll see you, all of you, in another symposium.
Yes, hope to see you soon.
Thank you so much. وتصبحوا على خير ورمضان كريم.
Ramadan Kareem for everyone.